create treatments to block various phases.
That's right.
That's interesting.
I agree. I've been really just intrigued reading constantly because it's a new bug, a new pathogenesis, a new pathophysiology. It's all extremely, well, I hate to say exciting because it's also frightening.
Of course,
but, from a scientific standpoint, it's intriguing.
Right.
Yeah.
Right. Yeah. I'm sure we will come up with some answers soon.
Yeah.
Right? By end of the year or early part of next year, I hope.
It sounds like it.
Yeah, we can't continue the way we are.
I know. And then also be prepared for something that comes, better prepared for something that comes again in the future.
Yeah. Right. Yeah. We don't know. There might be something COVID-22.
No, I was just talking about that to colleagues, right? We have no idea how this mutates and changes over time.
That's the part that puzzles me. How these things mutate.
Right. Right.
Yeah. Like a cancer.
I agree. Yeah. I think about influenza and the vaccine and having to get the right strain in the years when you don't. That toll it takes.
Mohan garu here andi.
Hello. Hi, God. Hello.
Hi.
So the Kavita is a long common name in that age group, I guess. Maybe in that age group is a common name.
Yeah, I think so.
I don't know. I saw same name in Northern Indians, Southern Indians, both.
Yeah. That's right. I grew up with about 3 growing up together, always thinking it was the other one people were talking about. So, yeah.
Hey, Edgar, are you here? Okay, how could you make me a little enlarge? See here.
Dr. Malam, how are you?
How could I make it?
Hi, Malanga, how are you?
Like that, but that's too much.
You need the gallery view. Yeah.
Yeah, Prem Reddy garu, I think andaru chudalante meer gallery view ga nokkalandi.
On the top next to the X mark there is a square. If you click on that, it goes to the maximize. Next to the X mark. To go to the
That's maximum. That's maximum.
Yes, right? That's it. That is the best you can get.
Oh, okay.
So
that sounds better.
Yeah.
I'll be here. Yeah.
So, Kavita, where are you practicing, Kavita?
So I'm in St. Louis now. Yeah, I moved from Chicago about 5 years ago now. Yeah. It's good. It's 100 degrees here today, though. So.
Oh.
Pretty hot. Yeah.
It's worse here, I think.
Say that one more time.
It's hotter in Alabama. We are in Alabama.
I bet that's true. Yeah, you got me beat.
President Trump is there in Tulsa, Oklahoma.
I know.
I haven't seen this thing. When the two weeks from now, we will know how many people got infected.
That's what I think about that. I know.
6 of his staff already got infected. 6 of his staff.
So we have we have 2 more joined andi. Raghav Reddy garu or Prasad Reddy garu.
Okay, that's good.
Raghav Reddy garu is opposite. It's like you have to be vertical. You are horizontal.
Yeah, I need to.
I think he's still connecting audio andi. Yeah, audio is not connected yet. Yeah.
Oh, okay.
Yeah, Anna Raghav anna koncham meer tippali dani phone tippali.
Oh, phone మీద ఉన్నారా? I see.
Yeah, he's in hospital andi.
Oh, okay. Yeah.
మీరు మ్యూట్ లో ఉన్నారండి రాఘవ రెడ్డి గారు? అన్మ్యూట్ ఇట్. I'm going to ask you to unmute.
Screen record. Okay. Record the whole thing.
Good andi. Raghav Reddy garu, we can hear you.
No. The video is not correct.
Audio. You can speak andi. You can speak the audio.
Okay.
Raghav Reddy garu, your video is not video is tilted andi.
Okay, నేను ఒకసారి చూస్తాను.
So you need to try again. Yeah.
webinar. Somebody asked me. Somebody asked me they are going for jogging. So can I listen to it after I come back?
Yeah.
YouTube will be recorded.
Yeah, it will be recorded on YouTube.
Okay. Varaprasad Reddy garu, how are you doing?
Namaskaram andi.
Namaskaram.
Namaskaram.
ఇప్పుడు ఎట్లా ఉంది?
No video అండి.
ఇంకా వీడియో రాలేదండి రాఘవరెడ్డి గారు.
నేను చూస్తున్నాను.
Yeah. Now we got the video there.
ఇప్పుడు జస్ట్ వచ్చి అలా పోయిందండి ఒకసారి మరి.
Yeah.
This is perfect, sir. This is perfect.
Much better.
Yeah.
So adjust the video.
ఓకే. ఇప్పుడు
బాగుంది సార్. బాగుందండి.
ఓకే.
Okay, that's good.
That's right.
So we have another 10 minutes, I guess. 10 minutes.
Yeah, I think Dr. Patel needs to join, right? Other than that, and Dr. Prasad G. Reddy garu.
Yeah, G. Reddy garu konచెం late అయినా పర్వాలేదు because he is later on.
Okay.
Yeah. Mohan, G. Reddy can call చేస్తావు? Can you call him? Prasad.
You need to join in the web or?
Yeah. Zoom.
I mean Zoom.
Yeah, I already sent the link through WhatsApp, Andy.
WhatsApp link, huh?
No, I already sent him through WhatsApp.
I can use WhatsApp or not? Does he have WhatsApp?
Yeah, he has.
He has WhatsApp. Yeah. But you can join directly from the WhatsApp also, Ramreddy?
No. He just need to click on the link.
అంటే వాట్సాప్ లో మన జూమ్ లింక్ ఉంది కదా సార్, జూమ్ లింక్ క్లిక్ చేస్తే జాయిన్ అయిపోతారండి.
Okay, I'm sending the email also just to make sure.
Yeah, I will call him.
Okay. Yeah.
And so you'll be moving the slides for us. I missed that part. Or do we just ask you to advance the next slide?
Yes.
Yeah, that's the plan. Yeah.
Yes, I will be presenting the presentation. So yeah,
Okay.
you can just say like next slide. Like that, yeah.
Sounds good.
Yeah.
Inko WhatsApp kada link పంపించాను. జాయిన్ అవుతారా వెబ్ లో?
Should I text Mohan Patel or should I wait? Maybe I'll.
That one just click on it and.
Yeah, he said like he's going to join like 5 minutes before or something. So
Yeah, I saw him briefly and then he logged off, I think.
Oh, okay. Then he must be joining again.
Yeah. Okay.
Dr. Varaprasad garu, how are you, sir?
అయ్యో నమస్తే అండి, బాగున్నారా?
Yeah. బాగున్నారా? We miss you. Yeah. So we have a talk next week. Or do you still want to do that, or how you want to do this?
Whatever you say.
It depends upon your energy. Like we are supposed to talk on vaccine research, right? We'll still keep that. Are you still okay with that? Or?
See, basically, I'm not a vaccinologist.
Right.
As an entrepreneur, I can talk superficially the time aspects of it, regulatory aspects of it, what is possible, what is not possible. Lot of misinformation is going on in India that it's coming yesterday, it's coming tomorrow, it's coming day after tomorrow. It's not correct.
Yes, sir.
I can.
So right now, one medication gives Fabiflu. There is a medication.
Yeah, Fabiflu. Yesterday, Friday, it was announced.
Right.
It is a good opportunity for that. They have done a wonderful job. Glenmark, they launched it.
I see. Okay.
It is the first oral tablet which can treat people, and its cost is not much, just $1.3 per tablet. We had to take 2 tablets on the first day, and after that we had to continue half the dose for 14 days. That's good enough.
For COVID? Is that for COVID virus?
COVID-19, yes.
COVID-19. I see. Okay.
The name apparently for that is Avigan in the United States.
Fabiflu in India.
I see.
Yeah, it's Fabiflu India.
Yes. And
not Tamiflu.
Sanofi, our partner Sanofi is coming out with Cavizar.
Okay. Yeah.
Cavizar.
The generic name is
Favipiravir. Hello, Nagi.
Hello, Nagi.
Hello, Dr. Nageshwar. How are you, sir?
Morning.
Morning for you. Yes. All right.
Thank you for your help during our global summit in Hyderabad.
Thank you. Yeah, sure.
నమస్కారం రెడ్డి గారు.
నమస్కారం. బాగున్నారు కదా?
బాగున్నారండి.
అది ఇందాక ఇప్పుడే లిస్నింగ్ ఫెవిపిరవిర్ గురించి స్టార్ట్ చేశాము. వచ్చేసింది అవైలబుల్ నౌ. బట్ ఓన్లీ థింగ్ ఇట్ బి ఓవర్ యూజ్డ్, అంటే మేబీ రాంగ్లీ యూజ్డ్. ఆల్ asymptomatic everybody start taking. రామరెడ్డి గారు, మీరు కెమెరా కొద్దిగా ఐ థింక్ నౌ ఇట్స్ ఓకే, లేకపోతే ఫేస్ సగం వస్తుంది.
హలో
హలో నారాయణ రెడ్డి. గుడ్.
హలో, మీకు వచ్చిందా? దాంట్లో నుంచి వచ్చిందా? వాట్సాప్లో మెసేజ్ వచ్చిందా నీకు? సరే, నేను చెప్తాను. రామరెడ్డి చెప్తాను. ఓకే.
Text.
Yeah. No, I will send an email.
Okay. Yeah.
I'll take about 11 minutes.
I'm ready.
11 minutes.
Email to Dr. G. Reddy Prasad. Hello,
Okay.
Ram Reddy?
Yeah, చెప్పండి.
మన G. Reddy Prasad కి email చేయి. WhatsApp is not able to do it.
Okay.
jprasad@earthlink.net.
Okay.
So Nagi, you leave 11 minutes, you said, right?
Yeah.
11 minutes. Yeah, that should be okay.
Yeah, CA Patel గారు జాయిన్ అవుతున్నారండి.
Yeah.
సార్ రామరెడ్డి గారు పంపమంటారా ఈమెయిల్ అది?
పంపించు, నాకు కూడా CC పెట్టు, just in case he calls me again.
Hello, Dr. Patel. Good evening.
Hello, Dr. Patel. Dr. Mohan.
Kiran bhai, this is Suresh Reddy. How are you, sir?
Patel ji, you are on the mute అండి.
Yeah, you need to unmute. So, Varaprasad Reddy garu, Miru, Dr. Patel.
Hi, can you hear me well?
Yeah, now we can hear you.
Yeah.
Good. So I will keep myself mute and I'll be moving to a quiet room.
Okay, Prasad garu, good.
Oh, good. Prasad joined. Hello, Prasad.
Prasad garu, you are on the mute అండి.
Mute. Unmute. ఇప్పుడు అనుకుంటా కదా.
Sorry.
Hello, Prasad.
Hello.
So everybody is.
Hey, that's good.
Everybody has joined now, so we are all ahead of time.
Dr. Prasad garu, this is Suresh Reddy. How are you, sir?
Hi, you're doing well, Suresh. Thank you.
Kiran bhai, how are you?
I didn't see you.
ఉన్నారు, రామరెడ్డి గారు ఉన్నారు.
Okay. ఇప్పుడు పిక్చర్ వస్తుంది రామరెడ్డి.
రామరెడ్డి వీడియో అన్మ్యూట్ లో ఉన్నాడు.
Yes.
Dr. Talwar.
Sir, what is
Dr.
the full?
Suresh Reddy is the busiest man.
What is the full name of Patel ji, sir? I will rename his name.
Kiran Patel.
Okay. Patel.
Yeah, let me rename him.
Okay.
Yeah, done and I renamed him.
Okay.
Suresh, I'm sure you're having several webinars today.
Yeah, we did almost crossed 50 now, 50 or 60 in the last 3 months.
Yeah, even very, very busy these days.
It's very challenging times.
Yeah.
So you met Kavita, Suresh, have you met Kavita? She's originally from Chicago.
Oh, hi, how are you?
Hi, nice to meet you.
Where are you now?
I'm in St. Louis, but Chicago's always in my heart. I miss it.
Nice.
Yeah, I know things have been difficult there too. The numbers have been quite high.
But not as bad as New York, but
yeah. Yeah, we're in St. Louis. It just hasn't reached those numbers here, thankfully. So we've been in good shape so far.
Suresh Reddy garu,
Go ahead.
In the ship itself, we had the corona. We didn't know the name at that
I
time.
know. Actually, when I came back, I became very sick. I don't know if you all know.
Same.
Varaprasad Reddy Garu and we went to Antarctica together.
Oh, I know. That's amazing.
Yeah, we got a chance to interact with him and we spent a few days.
We all have gone through that fever, same symptoms, but we didn't know the name at that time.
At the time, right?
And before us, and
antibody. Did you check the antibody level?
Before us and after us, the Chinese people went. It was a charter.
Yes. Same flight. The ship came from China.
It's coming good.
And I don't know if you know, the last trip of that ship, they were stranded for 2 weeks on the sea because they wouldn't let them port into
quarantining. Yeah.
Ram Reddy Garu,
we got immunized already by the ship.
NATA YouTube is good.
Yeah. When was this trip? What the date?
Antarctica trip.
I know. What date was that?
It was the last week of, we did one in November and one in last week of January.
Okay.
November we went, I think.
November, yeah.
So there is the only place where there is no COVID now. That's what I heard.
Yeah.
Yeah, that's what.
I actually met
Varaprasad. Have gone through that problem.
Yeah.
I guess we.
Yeah, Dr. Varaprasad Reddy Garu, he gave a great lecture on vaccines development and he gave a CME there. So on the ship.
Yes.
Great.
So you got the double benefit then.
Yeah.
So it's 8 o'clock now, Raghava. I think we can, whenever you're ready, we can start.
No, Dave. 1 second. Okay. Sorry. Give me like 2-3 minutes.
Oh, okay. That's
so
fine.
Everything will be live. We'll give a go ahead. 1 second.
Okay.
Ram Reddy akkada manage chestar akkada mana TV daggara.
So they're working, Andy. They're working. Okay. Yeah. So
okay. Can you hear me well now?
Yes.
Good. So
yeah, we can see you also. Before you were close.
I was in a restaurant, so I had to move out and get ready for the meeting.
Oh, okay.
Yeah. I'll still keep myself on mute.
Okay.
Nagesh Reddy garu, namaste andi. Na peru Subbareddy Meka.
Namaste.
Nenu actually I was one of your patient andi. హైదరాబాద్ లో మిమ్మల్ని కలిసానండి.
సుబ్బారెడ్డి క్యూర్ అయిపోయింది కదా.
అంతా సాల్వ్ అండి. ఎవ్రీథింగ్ ఆల్ రైట్ అండి. యా యాక్చువల్లీ మై నేమ్ ఈస్ షోయింగ్ యాజ్ నాట్ అ వెబ్ టీమ్ అండి అక్కడ. బట్ యా ఐఎమ్ వర్కింగ్ విత్ రామిరెడ్డి గారు. యా మీ వాయిస్ కొంచెం వినపడట్లేదు నాగేష్ రెడ్డి గారు. మీ వాయిస్ నౌ ఇట్స్ క్లియర్ అండి. యా గుడ్ అండి.
When you have slides, how does it going to appear? Like the slides would be on the side?
Ram Reddy?
Yeah. So slides, so Anna, like when, let me show you. I'm going to share the screen so you can see. 1 second.
Slide will be in the center. Your face will be on the side.
Okay. Your face will be on the right-hand side, top corner. I will share my screen just to show you.
Idi but recording.
So do you guys see the screen? Like I'm presenting something.
Okay.
A whole screen.
Whole screen. Do you guys see it?
Yes.
Okay. So yeah, this is how I'll be presenting. So where the right hand side NATA logo is, like on the top corner, your video will be shown there for the TV audience.
For the audience.
For the TV audience, yes.
Yeah.
Right.
Yeah.
Okay. All right. Sounds good to me.
Yeah. Thanks, Anna.
And Ram Reddy garu మనం రికార్డ్ బటన్ ఆన్ చేయాలి స్టార్ట్ అయినాక.
Yeah, you can go ahead and record it.
I'll do it.
నేను ఇక్కడ ఆన్ చేస్తున్నాను సుబ్బారెడ్డి.
Okay. Yeah.
Okay, so we're all
you have to record on the cloud.
Yeah. So Narayan Reddy and Subba Reddy, like once the show starts, we should all be in mute.
Yeah.
And if there is anything, you can call me.
Okay.
Okay.
I'm going on mute.
Yeah, sure.
ఇస్తాను. మళ్ళీ మీరు వెళ్ళిపోతారు కదా, కింద ఉన్నాయి సరే వేసుకోవాలి. ఎన్ని వేసుకున్నారు కదా? సరే నేను బ్యాగ్ పెట్టాను, కింద పెట్టాను. నా కంప్యూటర్ ఉంది కదా కింద, అక్కడ బ్యాగ్ జిప్ లాక్ బ్యాగ్ తీసుకొస్తాను.
So anyway, while we're waiting, I sent you a question, Dr. Talwar, from one of the...
Yeah, I think regarding Favipir, that's been answered already. It's not approved in USA, but it's been approved in Japan and India. So the studies are ongoing, but it has activity against many RNA viruses. So that's why ICMR endorsed it, and the company is making it. So we will see how that goes, but we don't have any experience of that medication in this country. So I can't say much about it from efficacy point of view.
Maybe question and answer session. Maybe you and Mr. Varaprasad Reddy can, or Dr. Nageshwar Reddy can answer that.
Sure.
When questions come.
Absolutely.
Dr. Talwar is not seen on the...
Why is it that?
Intentionally, I guess.
No, okay. No, not really.
Okay.
You have not joined with the video.
Is that right?
Now.
Yeah, hi, Talwar.
Where there? Thank you.
No problem.
So, okay. Sorry, Andy. So, yeah, we're all ready, Andy. So, yeah. Hello?
Yeah, go ahead. వినపడుతుందండి రామిరెడ్డి గారు వినపడుతుంది.
Yeah, keep going.
Yes. So we're all ready. So we should start the show. So Dr. Raghureddy garu, so you can go ahead and start with your president remarks. You're on mute, Andy.
Unmute first.
So unmute first. So Raghureddy garu.
Raghureddy is not able to
Still
hear.
let me unmute.
Yes.
Okay, go ahead. Yeah, go ahead, Andy.
Good evening, everybody. On behalf of North American Telugu Association, so we are having this webinar, COVID-19 Now and Future. I'm going to welcoming eminent people here, including Dr. Premanna, NATA Chairman Emeritus, and Dr. Nageshwar Reddy garu, Dr. Varaprasad Reddy garu, Dr. Talwar garu, and Dr. Kiran Patel garu, and Dr. Prasad J. Reddy garu, and Dr. Ashish Reddy garu, NATA Advisory Council member, and NATA Chairman, Dr. Mohan Malan garu, and also AP President, Dr. Suresh Reddy garu, and our NATA executive team, Al Ram Reddy garu, NATA Secretary, and NATA Treasurer, Narayan Reddy garu, and Subba Reddy garu, another NATA leader. And we are going to have this excellent webinar and with these eminent people, and they are going to enlighten us with a lot of information what's going on in the world. So thank you, everybody. And Dr. Ashish Reddy garu, can you take over from here as a moderator?
Okay. Okay, yeah, I'll be happy to. I was not.
Sorry, Dr. Kavita Reddy garu, I forgot to mention your name. Sorry about that.
Yeah, I think she's our rising star in this group. Anyway, thank you, Raghava. Thank you very much. Thank you all, these distinguished speakers. And unless I don't need to give a lot of introduction, especially for Prem. He is an eminent person, but I was under the impression that you were going to introduce Prem, but anyway, I'll do the best I can without preparation. He is a good friend of ours for the last 30 years, and he is a very prolific entrepreneur, philanthropist. He is actually his son-in-law. One time I heard him say that Prem is like, the Spanish expression, mi casa is su casa. That means my house is your house, like that kind of host he is. So he is a very, very successful entrepreneur, philanthropist, and he's one of the 50 most influential physicians in the USA. And then he is down to earth, and anytime we can reach him, and he is always willing to help. So he's also, last but not the least, he's a cardiologist, he's a physician, so he can talk in the physician perspective as well as administrative perspective, as well as entrepreneurial perspective. So he agreed to speak, and also he's agreed to stay the whole meeting. So with further delay, I want to go ahead and turn it over to Dr. Prem Reddy.
Thank you, Adi. Good morning to everybody in India, and good afternoon for those in almost good evening, I would say, in most of the East Coast. My time here is Pacific time, is 6:10. I'm asked to speak for only 10 minutes, so I'll try to limit, and I have my watch in front of me, and if I exceed, you could stop me. So these are unprecedented times. In our lifetime, we haven't seen a pandemic of this nature. And the whole world is fighting one enemy. Surprisingly, the enemy is invisible, okay? And you could probably see only in a microscope. All countries all over, like a third world war with the invisible enemy. I was just looking at the name, coronavirus. Corona means crown in Latin. So the enemy does have crown, not one, several crowns. Okay, and that's what his fighting tool is. So it has created, substantial horror and affected the entire fabric of life, medical, psychological, and socioeconomic status of the entire civilization. The global healthcare system is reacting. Many times we don't know how to react to pandemics, ill-prepared, ill-equipped, and because of the spread from one country to the other, and I believe during these spreads, even COVID-19 mutates, so it's not the same COVID-19 in Wuhan as in California. But hopefully that's what we take into consideration when we're developing the treatments and vaccines. The government of United States has launched vaccine invention on a warp speed. That's what at least President Trump uses, the warp speed. The best we could hope for is end of the year, because they're hastening the processes of trial in humans, as opposed to it takes almost a year and a half before it comes to human trials. But now, so many trials and so many companies scientists and companies are getting involved. Hopefully, we will have new discoveries with regards to therapy and ultimately with regards to vaccine and maybe more than one vaccine because the strains might change. So this enemy is still with us. We haven't made, I think the slides are going faster than when I'm talking. Could you control the slides and go back to the first slide? Okay, that's it. That's the first slide. My name is the first slide, but doesn't matter. I've been introduced, so that's fine. Just stay there, stay there. But on the left side, on my right side, are the statistics. But with the pictures, others can't see the statistics. So, Ramiredi, how are we going to deal with that? I mean, could you blind others and leave my picture only? Otherwise,
yes.
part of the slide won't be seen.
Right. Your picture only will be shown, Anna.
Right.
So yeah, we should be fine.
Right now, we can see the entire screen, sir.
Now?
We can see the entire screen.
See everything, Anna. We can see.
Oh, you could see?
Yes.
Yes.
On mine, I can't read my own.
Okay.
Global.
Okay.
I see myself and all others one after other. So I can't read my own slides. I think I could do without reading if you know yourself. Let me guess what it says. 8 million cases, 460,000 deaths. US is 2,200. I don't know how to translate into lakhs. US deaths as of Friday, 119,000 and still counting. At this juncture, I would give some statistics of my own experiences. As you know, I founded and I own a hospital hospital company with 45 hospitals in 14 states. My own experience is we have performed 45,000 tests at our hospitals, 5,300 positives for COVID-19, 4,300 patients were admitted and treated. And we have of the primary diagnosis of COVID, 191 patients expired. That's a 12% mortality, which is high. But you know, the denominator is small because we didn't do that many tests. Patients that came to hospital came with symptoms, at least initially. So this is not a reliable mortality rate, but something we need to wait and see. The next slide. I'm ready, or whoever. Could you show me the next slide? Okay. This is about coronavirus itself. It's called common cold. It's a single-stranded RNA, first discovered in mid-1960s. The surface spikes of glycoprotein, otherwise I call them crowns, are the most potent and most important element of this virus and its spread. Animal reservoir is mainly bats. It's a dominant reservoir, but there are intermediate hosts of various degrees. Like if you go to the next slide, I think there is something more. Could you go to the next slide? Okay, so we had three kinds of epidemics, not pandemics, outbreaks, call it. SARS in 2002 and 2003, that's COVID-1. MERS, it's a Middle Eastern Respiratory Syndrome in 12 on, and now COVID-19. which is SARS-CoV-2. And that's what we are dealing with. Could you go next, please? Actually, my picture there looks better than in real life, so I might as well just have it. Okay. It started actually in Wuhan province of China, and especially in one seafood market. That's the picture of that market. It's called Huanan Market. It's from New England Journal of Medicine. From these animals, the bats transmit to them, and then by either by bite because they're bloodsuckers, or by dropping species which these animals eat. You know, the feces have high concentration of virus. I'm sure Dr. Nageshwar Reddy would be talking about it. And so there have been several animals throughout. SARS-1, the main culprit, the intermediary host, was called civet cats. I guess they eat the cats in Wuhan and in China. And the present intermediate host is pangolin. You know, pangolin, I never saw pangolin other than pictures. It's like armadillo in America. It has the spikes, and apparently they eat the meat, it's delicacy. And also they use these spikes for treatment, like, you know, like the shark fin and snakes and that kind of stuff. So that's how it spread there. One of the important thing, you know, people, especially President Trump, blames China for everything, calls it a China virus. But you know, wherever it started, it's now a world virus. We all need to deal with it. But the important fact is the Chinese. The first announcement came on December 31st, 2019. Gene sequencing was completed very quickly by January 7th. In 1 week, they sequenced the gene. And China shared the diagnostic test by January 10th. So within 10 days, China came with the grips with the virus. And of course, they put everybody on quarantine, forced separation, forced quarantine, and they were able to restrict at least to Wuhan, even though now it is spreading other parts like Beijing and all that. Next slide, please. Oh, it's going to take time here. Okay, I'll go quickly. This is COVID on the left side. That's the COVID virus. And you see all those spikes. Those are the hallmark of this thing. The middle one is the spike, electron microscope of the spike. The right one is where that spike gets hooked onto ACE2 receptor. You see that maybe blue? That's the receptor. And that's how it transmits. Okay, so every one of those spikes could infect. Next slide, please. Okay, this is pathophysiology, and it's complicated slide. Instead of me going through very details, a couple of points I want to make. The virus, as you see on the left hand, it goes through proteolysis, called proteolytic activation. So it separates the protein S1 and S2, and that S1 is the crown, and that gets attached to the cell membrane, and that's how it spreads. So the importance of that is the treatments and vaccines are going to focus on how to block the receptor binding, how to increase prevent or minimize the proteolytic activity, and how to prevent the fusion. So if you know the pathophysiology, you know the treatment, how to go about treating. Next slide, please. Okay, this is the pandemic spread from Wuhan to Europe and to all the parts of the world, and you see the United States. Okay, now it says that it mutates in the process, so that's what I mentioned earlier. Could I move on? Next, let's go faster, please. Okay, the COVID-19 infection is about 2.6 times compared to 1.3 of common flu, seasonal flu. So if you look at the 5 infected people from common cold or seasonal flu, by 5 cycles, 45 people get infected, whereas 5 infected COVID-19 patients, by 5 cycles, you have 368 infected. You see the multiplication and you see the cluster. Visually, you could see the difference between seasonal flu and COVID-19. Next, please. Okay, and this is the pandemic. I took an area of, by the way, I don't know whether I mentioned during the talk, these slides were given to me by a close friend of mine from my school in Tirupati, who is a practicing physician and a good friend of mine, Dr. Nanda Kumar. This section takes from February, middle of February, and by March 15th, look at the spread, how pandemic it became because of this multiplication. Next slide, please. Okay, this is United States. I don't see the spread in the United States. In the 2 weeks, you see the upswing there in United States from March 1st, actually first week of March till end of the March, it became nationwide in the United States. Next, please. Okay, I don't go too much into this. Okay, 45% of COVID victims are asymptomatic. The next important point is pre-symptomatic transmission is 45% of the cases. See, put those 2 things together. By the time you realize you had a contact, so you got infected when the vector or the infected person is asymptomatic, and most peak period is on or before the symptoms start. So it's a very deceiving. Next, please. Next slide. Okay, diagnostic tests, you know that. The point I want to say is that this test, fluoroimmunoassay, is now being done in the United States hospital, in our hospitals, so that within an hour you have a result, and then you could do elective surgery if the result is negative. The predictability, the specificity is 100%, but sensitivity is only 88%. And then most commonly done is PCR, that's polymerase chain reaction. That's again 100% specific, but sensitivity is not as not 100%. Okay, moving on. The other tests that are being done is serological tests. Another test that is becoming very modern, I don't know how much it is being tested, CRISPR, where they're using the technology of gene editing. You know, they edit the genes. Right now it is diagnostic only, but then it is going to become therapeutic in future with gene editing. And I don't know when that's going to be, but it's going to be sooner than later. Another test is the company name is Biotech Pioneer itself. The name is Biotech Pioneer. They're coming up with a strip, which is, you know, amazing. It's like you do a pregnancy test. You know, you pee on it and you tell whether it is you're pregnant or not. The same way, you dip it in, I believe, in blood sample, and you could tell whether you have a COVID or not instantly. Now, I'll address a few therapies, you know, pharmacological therapies. You know, we're still experimenting. Remdesivir is the only one that has been. Next slide. Remdesivir, go on. Yeah. is the only one that has been tested to minimize the course of its antiviral drug, you know that. Chloroquine, highly promoted by President Trump, but it's only clinical trials at the present time, but not prescribed in other places. The other therapies is convalescent plasma and hyperimmunoglobulins, and we are using it ourselves. Some of our hospitals have entered into the trial. We are using convalescent plasma, and then immunomodulation therapy, which is under. So if you look at the immunomodulators, interleukins and cytokinase. This virus causes cytokinase storm, and that's what causes the pathology. And so these immunomodulators, some of the names are here, and then everybody's experimenting with everything else. And I was pleasantly surprised to see there's a pilot study of sildenafil, Viagra, because it's a vasodilator, it reduces the pulmonary hypertension. So that's one of the treatments. And then next slide, please. So like I said, in pathophysiology, the treatments are focused on addressing the pathophysiological sites, like ACE2 receptor, blocking the entry to ACE2 receptors, blocking the S protein from attaching to the cell membrane by inhibiting the protease, so S1 and S2 doesn't split, and human monoclonal antibodies, and these are other drugs. Formatidine, it's I believe Pepsi, right?
Yes.
Yeah, it possibly binding the protease. It inhibits the effect of protease in intravenous dose, and I haven't done that. We were talking before the meeting. Favipiravir is called Fabiflu in India. Here is called Avigan. Okay, so I don't know much about that. No personal experience. And the one I've been using for years and years, dipyridamole or Plavix, is supposed to be used for. It's again works through protease. And anti-parasite drugs like chloroquine. This ivermectin is an anti-parasitic drug which is supposed to act in the viral replication. So my next slide, please. This is my last slide, and I might have taken 3 minutes more. I'm not going to go into details about this vaccine because Prasad Reddy Garu and some other speakers might be talking about it. Just mentioned about the studies that are going on, University of Oxford, BioNTech, Pfizer, Novavax, recombinant vaccine, and Johnson & Johnson. And also recently you heard it's evolving, the treatments. From Oxford, you also heard treating with dexamethasone because of the, when it is intense, not early on causes more harm, but when the pulmonary inflammation and the inflammatory exodus, this dexamethasone decreases. This most in the last 2 weeks, we've been hearing about it. And like that, there are several therapies being explored, and we have to wait and see. With that, I stop here and to give time to the others, and I will be around towards the end to answer questions. And I have a lot of personal knowledge of talking to the doctors, and only one doctor died who was exposed to while treating the patient. And like many doctors do, he didn't come to hospital, stayed home and went on into distress and taking nasal oxygen, but they overwhelmed him, and last minute he called and came to the hospital and expired on the way. Other than that, we didn't have mortality among the doctors, even though we did have in 3-4 about frontline workers. And with that, thank you very much. Let's move on to the next speaker, and Adi, take on.
Thank you, Prem. Excellent job. Great overview. So the next, yeah, you did put in a lot of work, a lot of effort, Prem.
Thank you.
Yeah, you're welcome. Next speaker is Dr. Kiran Patel. So his topic is a little bit different. Actually, I need to go ahead and give, yeah, you can give the overview of the speakers. You know, unless you are sitting in a cave or something for the last 5 years, you would know all these speakers. They're very well-known people. Most of them are very well-known, and some of them are still rising stars. So I think to be respectful to the speakers and also to the audience, I want to introduce each one at a time so that they would remember which speaker it is. So next, let me go to Dr. Kiran Patel, who is graciously agreed to speak. Dr. Kiran Patel is an honor and privilege to present Dr. Kiran Patel, who is a serial entrepreneur, humanitarian, and philanthropist. He was named Floridian of the Year 2018 by Florida Trend magazine. His focus is on health education and general education. He has built many hospitals. I don't know exactly how many, but he has built hospitals, schools, and colleges in 3 continents. Okay, mute please. His Janmabhoomi is Africa, his Karma Bhoomi is America, and his Matrubhumi is India. He has built 2 HMO plants with revenues of over $1 billion each in the United States. He has built 2 medical colleges, 14 paramedical colleges, and a college of global sustainability. So he is well suited to give this topic, the effect of COVID-19 on education, both health and otherwise education going forward. So I'm turning over to Dr. Patel.
Thank you. My good friend Prem had taken a few minutes extra, so I will try and help him by cutting my talk to 5 minutes.
Thank you.
My views are gonna be a little contrarian, provocative, and basically, as Prem mentioned, this invisible enemy has created a havoc globally. But if I focus only on United States, unfortunately, we are in an era where there is significant political divisiveness. We cannot trust the media. In the past, your source of information used to be reputed medical journals, but today with internet and all, you can get all kinds of information that sometimes are not verified. It's a wild, wild west. As you know, the data can be manipulated because when you look at the number of tests, the age, the comorbidity, mortality, lots of inferences can be made, and we will have to wait and look at all these things 6 to 12 months from now. The biggest challenges we have is to find a reasonable cure, and more importantly, the vaccine. And everybody is working hard, and there are many good speakers who are going to cover that topic. What I want you to understand in education in this country, I can give an example of University of Kentucky has 30,000 students, but 18,000 employees. These type of statistics are mostly seen in all universities. And I bring this up for a particular reason. And when you see universities today advertising and telling they are open and they're going to be taking students, while they show a public optimism, there is, of course, a private uncertainty. the basic rules of social distancing, etc., will be followed at this stage. I am currently in a restaurant which is overpacked and nobody is wearing a mask. And things are already starting to go back to normal. And I bring this up because how can you imagine a university where there is no interaction, no interaction among students, no sports? So these Zoom meetings may not be a way to go, but currently in these challenging times, quite a few lessons have been continued. But when you think about medicine, where you have to deal with interaction, actual live patients, humans, etc., it's only a question of time before things will be back to normal. So I am an eternally optimistic guy, and I believe that while there'll be some permanent changes, just like what we see at the airports, there will be in the classrooms, etc., where the distancing is practical and possible, but at other places, there'll be close interaction, especially in medical field, because you have to deal with patients face to face. The televideo and telemedicine is becoming a huge factor, and that primarily has become a factor only for one reason. And that reason is now the government is paying a physician or a provider for using that tool. Unfortunately, when you think about capitalism, if you have capitalism without ethics and morality, lots of bad things can happen. So what I am telling you is you will see a permanent change. Telemedicine, distance learning, all is coming. But I believe that it's a question of time. And within the next 6 to 12 months, especially the vaccine is available, life will go back to normal. So I will end by telling you that currently in this environment, we do not have adequate data, adequate information, and adequate results to be an authority. As you know, in United States, they were complaining about respirators. There was no issue of respirators. They were complaining of tests that has been overcome. So you will see that many of the fears are really unnecessary. While we don't have to be overly optimistic, as a society, as a community, we will all have to find a way of going forward and normalizing the life. And I'm very, very confident that over the next 6 months, life will be back to normal. I will end here and I will be excusing myself. So if there is 1 or 2 questions, I'll take it. Otherwise, there are many, many competent speakers, prominent speakers that will be able to answer lots of questions with time. Thank you for giving me this opportunity to address all of you.
Yeah. Thank you, Dr. Patel. And it was certainly very provocative and informative. I didn't get any questions from the audience, but is the speaker panel, is there anybody who has any questions for Dr. Patel?
Okay, thank you. And I'll let you proceed because you have a great panel of speakers waiting. Okay. And hopefully I made up the time for my body and you will be back on track on the routine. Thank you all. Okay, good night.
Thank you. Thank you very much, Dr. Patel. Nice.
Could I make one announcement, Adi?
Sure,
Could you,
please.
somebody is talking on the phone. Whoever is talking and have the phone open, could they put it on mute, please? A lot of people talking somewhere, maybe in India or here.
I think there's a restaurant where Dr. Patel is eating.
Oh, that's from the restaurant. Oh, okay.
Yeah,
Oh, that solves the problem. Thank you.
Okay.
That's what he said. He's in a restaurant.
Yeah, I'm glad with yeah. I thought some kid was doing one of our
No.
restaurant, so that's good.
Yeah.
So okay, we can move forward now. We got Dr. Talwar is next. Dr. Talwar is a pulmonologist, critical care specialist, and professor of medicine at Northwell School of Medicine in New York. He's also a prolific researcher, and Dr. Talwar has been living and breathing for the last 3-4 months. COVID-19 has been his life. I think he is probably putting like 60 to 80 hours a week. He has unique qualification that he is also a patient of COVID. So he has both as a doctor and as a patient, he can give his perspective. Where else could we find a COVID-19 patient with so much knowledge as Dr. Talwar? So Dr. Talwar will be taking about his topic is clinical stages of COVID-19 and outpatient management. Thank you, Dr. Talwar. You can proceed.
Let me see if I can share my screen. Yeah.
Okay.
I'm trying to see if I can share my screen with the audience, please.
Okay,
So
yeah, please go ahead and share.
It's saying that you have disabled.
Okay, so 1 second. So Subbareddy, you need to allow Dr. Talwar to share.
Yeah.
If I could. If not, just put the other slides and I can go continue because time is of importance here.
Yeah, I'm almost done. 1 second.
Sure.
It's in the share mode. Actually, it's allowed.
Okay, yeah. So
now it is allowed.
Yeah.
Yes. It is allowed, sir.
Go ahead, Dr. Talwar.
Yes.
Yeah, we can see your screen, sir.
Thanks for the kind introduction, Dr. Reddy, and the previous two speakers have already kind of covered and laid the groundwork for what COVID is and how it actually affects the human race. My next 7 minutes or so, I will try and put it into the right clinical perspective from a clinician point of view who has seen and treated these patients and also have contracted COVID and actually gotten recovered from that as well. I go back to 1965, and I will try to remind everybody that at that time, the Surgeon General, William Stewart, has made a quote, which still reverberates the books of medicine, if anybody cares to read. And it says, "It is time to close the books on infectious diseases and declare the war against pestilence won." Pestilence, by way, means an endemic, or rather pandemic. Those were futuristic words at that time, but how wrong we were to think that we have conquered the world of infectious diseases. In 1980, the humankind had to deal with the HIV infection. In 1990, drug abuse and hepatitis C and B infection. Then SARS-1 infection. In 2007, 8, and 9, MERS infection. And lo and behold, after 40, 50 years, we are back to the square one of the checkerboard because we are dealing with an infectious disease, which we thought we had conquered a long time ago. Part of it has already been mentioned, so I will just steer away from things which I think clinicians and common people must understand as to why COVID-19 virus is so infective and how is it so different than the common flu and other coronaviruses. We have more than 10 coronaviruses that we are aware of. but this is the only one that is deadly. It is because not only it has the spike proteins that have been mentioned before, but also troubling is the fact that this virus uses an enzyme which is called furin, which helps to cleave the viral spike proteins and allows it then to get inside the human host cells, which is the respiratory epithelium, take over, demand from the cellular DNA to reproduce more viral RNAs, and it proliferates and then it's thrown out into the body. So it is not only very effective, but it's very proliferative as well, which kind of explains why the infectivity is so important. And I will remind you once again, it was mentioned before, the reproductive number, an unchecked population is 2.5. It means one person will affect 2.5 unless and until protective efforts are made to stop it. It is not only angiotensin converting enzyme, and I will come back to that because it has connotation with Indians and diabetes, and I'll come back to that in a minute. So what are the risk factors, folks? The risk factors are older age, chronic lung diseases, chronic heart diseases, hypertension, coronary artery disease, diabetes is being covered by another person in the end, history of obesity, immunocompromisation, renal disease, liver disease, means all chronic conditions, but I'll add two more to it today. One, we just recently found out this week that people with blood group A are more prone to this condition. That doesn't mean they have higher incidence of dying from it, please, but they are more prone to it as compared to those who are blood group O. Secondly, we also know that from New York and Wuhan and Italy experience that up to, in some centers, 20% of those exposed were healthcare workers. It doesn't have to be doctors, it doesn't have to be nurse, it doesn't have to be pharmacists, but those who had some connection to healthcare entity. So that is a risk factor itself, and I would urge every physician or every healthcare worker, because the surge has moved out from New York and it is right now pandering the western and the southern coast of this country, and that to some parts of India as well, from including Gujarat, Bombay, and Delhi, and even in down south as well. Please be careful about it. So how do, as a clinician, or how do, as a common man, I want to think of this disease or this virus? We know viral infections, how they infect, we are very clear about it. But there is a prodromal stage, even before that, before you get infected, and you get it by inhalation or by touching any area from which you can get it. That's where comes the idea of cleanliness and hand washing. But initially, the first stage after the prodromal, first stage is that of fever, tiredness, fatigue, anorexia, loss of smell. And this is the time when most people tend to ignore it. But if you ignore it, sometimes the fever will go away, but it will come back in the second week, which was called as the immunomodulatory stage, or as was mentioned before, the cytokine storm. The infection has occurred in the respiratory epithelium in the first stage. The virus is now, the body is trying to develop antibodies to this virus, and suddenly those antibodies and the things that cytokines that body releases to bind or hold the virus end up damaging the body itself. If it damages the liver, hepatitis. If it increases LFTs, but most commonly it will damage the lung, and you develop pneumonia-like features, more of it, shortness of breath, etc., etc. And if it develops the kidney, you'll have renal failure. It goes to the brain. You will have strokes, encephalopathy as well. But most common organism are the lungs. And let me put it in the right perspective. If you look at the large population, the actual mortality of this infection is 1%. And by way of comparison, the actual mortality of influenza is 0.1%, so 10 times different. But as was mentioned by Dr. Reddy, in his hospital, it is around, his mortality rate is 12. And we in New York had a much higher mortality rate as well. So it depends what population you're looking at. In any area, large area, there will be 1 to 5% people may be asymptomatic carriers, means they have the virus and they are not having symptoms of shortness of breath, fatigue, tiredness, anorexia, loss of weight, etc., etc. But 80% of the rest of the population have mild disease. So we should need to calm down. Most people will get better. Another 18 to 19% patients will have a moderate disease that will require them to be admitted. And of these, around 10% or 1% of the entire population will need to go to the ICU because they will develop end organ damage. What do I mean by that? You will have respiratory failure requiring intubation. You will have renal failure requiring hemodialysis catheter. You may have stroke or a combination of these. So pre-symptomatic stage, first week of mild symptomatic stage, second week of these immune modulatory stage, third week in which the patient starts to develop more further end organ damage. And now we have learned that this virus not only affects the organs per se, but it makes us more thrombogenic. So people start developing strokes, pulmonary embolism, clots in their legs, clots in the renal arteries, mesenteric ischemia, etc., etc. So this virus takes you through 4 of these stages. The 5th stage is the resolution and convalescence, in which people get better. But I do want to point out, having treated many of these patients now, that the treatment, the management of this condition doesn't stop in 3-4 weeks. Patients will take up to 8 to 12 weeks for their tiredness, fatigue, and their anorexia, and to get better. Something that clinicians must educate their patients as well. And those who have suffered, or their loved ones who have suffered from this, must be aware that this will take a longer time to release, to get better. It's the same thing I put it on here. Some of these things, we do see lymphopenia in there, with the lymphocyte count is low, very counterintuitive. That is a poor prognostic marker. We look at chest X-ray, CT, and other abnormalities, increased LFTs are also prognosticated in the sense of poor mortality. CAT scan, chest X-ray will show these changes. CAT scan may show these changes. They are more peripheral, etc., etc. The point that I'm trying to make it, not everybody needs a chest X-ray, but those patients who are short of breath and need to go to the emergency room should get a chest X-ray. Bigger the infiltrates, bigger the damage to the lung, obviously bigger the mortality. And here comes the role of steroids. Last week, Lancet has put together a little article about dexamethasone study in UK, which shows that there was mortality benefit in patients who had these kind of changes that I'm showing on my slide. And these patients did show, when they were intubated or even they were requiring oxygen, high oxygen therapy, there was a mortality benefit from 40 to 23%, basically telling steroids have a role in very severe disease. It has no role in mild to a form of disease or those patients who are not short of breath. So not everybody would need steroids. Again, we also use extracorporeal membrane oxygenation in many of these hospitals, in my hospitals as well. But the more we use it, we realize that this may be one of those areas of scarcity resources, because this may not be available in every place, in every country, and every hospital. It does help. It helps till the time, think of it as like a dialysis machine of the lung. It helps till the time the lungs recover, so that the oxygenation of the body can continue. These patients also are at high risk for pneumothorax, lung cysts, and interstitial lung disease can develop down the line, because this is one of those viruses, even when it has damaged the lung and has gone away, long-term you may develop fibrosis. I would put this in the other context. Think of the hepatitis virus can cause cirrhosis. I think of this way, this virus, our COVID-19 virus, which likes to invade the epithelial cells and the endothelial cells of the lung, leads down to proliferation and damage in a way that patients will develop fibrosis. So patients who have moderate to severe disease, even when they get better, may still be left with poor lung function and damage to their lungs. Okay, I've kind of put together as to why this is such a severe disease and why is it different than other. I kind of covered that before. The tests have been put together. Sensitivities were mentioned before. The antigenic test is a quick test, but again, it's positive. It may have false negatives. The sensitivity of the PCR test is not as good as we would like it to be. And the antibodies more have a role in epidemiology. It just tells you that you were exposed to the virus. And generally the IgM antibodies becomes positive in the second week. The other antibodies become positive, IgG becomes positive in the third week. In the limited time, I would like to point out a few other things because I knew Dr. Reddy was going to point out some of the medicines that he had talked that have been used for this condition. As of now, the drug that's approved in USA remains remdesivir. What is the evidence? 2 different studies showed that patients who were on the ventilator, again, not people who are at home, those who are on the ventilator, when they got these medicines, they improved a little earlier as compared to those who didn't get it. So remdesivir is a good drug, but it is not the panacea. And secondly, it is only available as IV. Thirdly, it can have other major side effects as well. It is not to be given in renal failure. It can cause LFT abnormality. So this is a very specific condition. What else do we have? Dexamethasone, again, for very sick people who have lung damage, very specific area. Hydroxychloroquine and chloroquine have been mentioned before. We're not using in this country now, but it's obviously used in many other parts of the world. The jury is still out. If you look at the basic science, it's an immune modulator in the sense that it does affect the infectivity of the virus by upregulating your immune function. How effective is that is not clear. My own personal view, in mild disease, if you take it, probably it is better. But what happens in first few days of the disease process, you have tiredness, fatigue, little bit of fever. Who goes to the doctor at that time? Nobody. And that's why the initial phase in which these immune modulators may be more helpful generally is missed because none of us and most people don't seek the help, or the help is not available to the general public at that time. I would also point out patients who are very sick, we are putting them on blood thinners because Dr. Reddy mentioned about some of his medications like Plavix, but the drug of choice in my mind remains low NOx or low molecular weight heparin, or if the need be, you can use newer NOACs or anticoagulants as well. Because we know in 3rd and 4th week, in those patients who have high D dimers, one of the lab markers, if they are elevated, these patients are going to develop thrombosis in their blood, in their blood vessels, whether it's in the stroke, portal hypertension, pulmonary embolism, DVTs, mesenteric ischemia, etc., etc. Mention has already been done of favipiravir, a medication which actually has very good activity against the common flu and is being studied and approved for treatment for general flu in Japan, then in Germany, and now in India as well. It is an oral medication. Again, it's in a way, it acts against the RNA polymerase, very effective drug. But I would say with a little bit of caution, we know many medicines which in vitro means in the lab, they look great, but they're not as great when it comes to the human host. I will mention how we can do other things. Please think about the mask. The masks, everybody should know, it should cover the nose, the bridge of the nose. Let me go back. Bridge of the nose till your throat, below the chin. That only it's effective, otherwise it is not. And why hand hygiene is important, let me put the scientific evidence. Hopefully that will convince people to use it and physicians to use it. The virus is a double virus. It's a particle inside and then a particle outside. The outside particles are hydrophobic, means these balls that I'm seeing on this virus on the right-hand side, they are very similar to what the soap particle is. So when you use water and soap, it washes the virus from anywhere. So folks, in my mind, 3 things: the social distancing, using a mask, but most effectively for healthcare workers, even if just washing hands with a simple soap will prevent the spread of the disease, because if you have to decrease R0 from 2.5 to less than 1 means each person cannot affect more than 1 person, even less than that, then only this virus will go away. We'll leave you with a thought and we'll develop this further. We need to think of life in a different way. Dr. Patel mentioned it. McKinsey and company have put together a nice model as to how leaders can change and act in these situations. It is a 5R model. Please allow me to say 1 second about it. There should be a resolve, meetings like this, education, and the leaders should have the resolve to meet the challenge. We have done that. There should be resilience on part of the public, the people in general. They should be doing the 3 things so that we can track, treat, and trace the people who are prone to it, and also who are harboring the virus and affecting it. Third is return. We need to return back to our work, back to our basics, in some way. Start to restart your business. You start your work. Telemedicine is an example as to how physicians are returning back to their effective work. Fourth thing is reimagination. The physician's office is being reimagined. The procedures are being done in a different way. And if time will allow me, I will elaborate this further. And lastly is reform. Gone are the days, and I believe namaste is much better than shaking hands. The whole world has finally come around to accepting it. That would be one such simple reform, but there are many such ways of thinking it. So all of us should think of everything that we do in our life in this 4R: resolve, resilience, return, reimagination, and reform. And you will see, you will make a change in your own self, in your own society, in your own country. The outcomes will be much better. Thank you much for your kind attention. I will stay back and for any questions, comments, or jokes at this point of time. Thank you.
Thank you. You have a great command of this subject, Dr. Talwar. You have passion and compassion for with patients and with this disease. So we are fortunate to have you, and then we want to stay on and to the second part of your talk.
Sure.
So we'll come to that. I appreciate your time. So we won't take further. So we'll go to the next speaker, Dr. Nageshwar Reddy.
Yes.
So I'll go ahead and introduce Dr. Nageshwar Reddy. Dr. Nageshwar Reddy, fondly called by friends as Nagi, is a dear friend, an accomplished researcher, and the world's best GI endoscopist. I have personally seen his endoscopy skills and can attest to that he is the best endoscopist in the world, especially when it comes to ERCPs. He is the son of our Guru Garu, Dr. Bhaskar Reddy, the former principal of Kurnool Medical College. So we have a lot of respect for his father also. Dr. Reddy is the chairman of the Asian Institute of Gastroenterology, Hyderabad. He has received numerous awards, including Padma Bhushan. We are very lucky to have him as one of our speakers. And he'll be talking about COVID-19 situation in India and also from GI perspectives. So it's a combination talk. So Nagi, without further ado, I'll turn it over to Dr. Nageshwar Reddy.
Thank you, Adi. I'd like to thank the NATA for the kind invitation and for asking me to be a part of this very distinguished panel. What I'm going to do now is to give a brief on what's happening in COVID in India and a little on gastroenterology. I realize that a lot of audience is lay audience and not doctors, and therefore I think we require to go past actual science into something what's happening in India. It may be interesting. So I think you have to stop sharing your slides so that I can put my slides on.
Okay, Narayan Reddy, go ahead and share.
Yeah, I think you have to shift so that I can get my slides on. So I'm going to share my slides from here itself. So if you can.
Yeah, that setting is on. Yeah.
Setting is
on.
Yeah. You should be able to share your screen.
Yeah.
Yeah.
Yeah, we're good, Andy.
Okay. So I think you'll be seeing my slides soon. As I said, it's going to be a little general talk on what's happening in India because some of you may be curious out there, and also a little on gastroenterology because I'm a gastroenterologist. So briefly, what happened with COVID in India was that in early March, we started seeing some cases. In fact, the first cases were students returning from Wuhan to Kerala in January end, but in February, we started seeing some cases. It was only in somewhere around March beginning that we started to realize the nature of this disease. And as you can see from the graph here, since then there's been an slow increase in April, May, but an exponential increase subsequent to that. So we have now reached a total of almost 400,000 cases. Fortunately, the mortality is only 12,000 now, up to now. And this is again showing you the more recent data. That's what's happening. The last few weeks, the cases have been increasing by about 14,000 a day. By American standards, they don't look large, but what happened in India was that it used to be 1,000, 2,000. Now it's coming to 14,000 every day. But what's important is the fatality rates are only about 3.3%. And this is, I think, a positive thing for our country. But what is very different in India is that if you actually look at India as a whole, there's a huge geographical variation that is occurring. In fact, some parts of India, like in Maharashtra, Gujarat, Delhi, and Tamil Nadu, are having very high incidences. This is partly because of increased testing, but partly because we still don't know why, whether it's a different virus. In fact, what happened in India was there's been a lot of genomic study of this virus at the National Institute of Virology in Pune. There's several different genomic types. There seems to be one, the milder variety, which came from China, the more aggressive one, which seems to have come from Europe. So you can see from the Indian map here that although all of us, all the Indians are in the same storm, facing the same storm, we're in different boats. The boats are different in different parts of the country. The boats are different, whether you're rich or poor, or whether you have access to healthcare or not. So a lot of difference. And that's why there's this huge demographic difference that we're seeing. So what happened was that although we detected the first case in January, it was only end of March that the government actually realized the gravity of the problem. And the first lockdown came on 24th March. And then subsequently, based on modeling that was done in Cambridge and other places, Indian government decided to increase this lockdown. It went on up to early part of June. There were 4 lockdowns. And finally, in early June, there was unlocking. What happened in US earlier, but unlocking happened here at that point of time. Our lives have changed since then. In fact, before Corona, this is what hospitals, this was a typical outpatient in our hospital. And you can see what happened after Corona. It's absolutely getting empty. So this is a dramatic change that occurred in at least the physicians' lives. Also, getting to the doctor is becoming more difficult. And then this is outside the lobby of a hospital. You can see that there's a long queues waiting because the patients then go through a sanitation chamber, which is becoming common in India, and then go through checks, screening like in the airport. They distance themselves sitting at distances. Then you can see that they have their checks done. And finally, to reach the doctor would take them at least 2 hours. Normally, it's long in India, but it's getting much longer. So the lives of the patients have also completely changed. Our dresses have changed. And of course, we are now aware that as I think as both Prem and Dr. Talwar have pointed out, that we have to be careful as healthcare workers. And this is what we're doing now, that most of us used to do endoscopies casually. We just are gowns on, but now we have all these shields and masks and so on. And what is very important, and this is what we learned from the experience of what happened both in China and Italy, talking to friends there, we find that if you're protected properly, the chance of a healthcare worker getting infected is extremely low. Our healthcare worker infection used to be high earlier, but now it's come to almost zero because of the protections that we're having. And this is very important. Now, coming to the GI part, I'm a gastroenterologist. Initially, when this virus came, we thought, oh, we are not involved. It's only the pulmonologist. But we realized that 1/3 of the cases can have gastrointestinal symptoms like diarrhea, nausea, and so on. This is because the virus, the receptors for the virus are present in the whole gastrointestinal tract. The virus is present in the stool in 50% of the patients, even after it's absent from the respiratory tract. And this is very important for future epidemiology because it may be spread into the fecal-oral route. 10 to 50% of the patients have liver injury, especially if it's an underlying alcoholic liver disease or non-alcoholic fatty liver disease. There's more chance of liver injury because the receptors for the virus are also present in the cholangiocytes in the liver. But the most important thing about the gastroenterology is that this 1/3 to 2/3 of the patients in some series actually have loss of smell and loss of taste. And this can present very early. I've seen patients who come and tell me I've lost smell and lost taste. When we didn't know this earlier, we just say, okay, try some medication. But now we know this can be the earliest symptom of COVID, and we are very careful in observing these patients. Of course, coming back to non-specifics, the lockdown had several benefits in our country. We had capacity building. We had very few ICUs, very few ventilators, but this has increased now. We now understand the disease so well that some of the therapies are being placed in a proper place. And of course, this mortality surge that could have occurred is probably hasn't. But there are, of course, the downsides. And one of the most important downsides that happened in India, especially, was how this disease got stigmatized, mainly because of politicians who came and talked about variety of things. So it's got a huge stigma now, so much so that unfortunately we know that majority of these patients recover, only about 3% mortality, small percentage require hospitalization. But the word corona has now become so dangerous to our lay public that people are not reporting if they have fevers. And this is causing more problems. In fact, I've had many patients, I see them and I say, oh, I'm sorry you have a cancer stomach or cancer colon. The first reaction of the patient is, oh, doctor, thank you, it's not corona. No? So that's so much of stigma that they feel is more dangerous than cancer and so on. Also, when the lockdown was removed in this country, people thought the virus has disappeared. So what happened was that we sort of unfortunately exposed ourselves like this. You can see the wine shops opened first, large number of queues with patients who are not masked also, who unfortunately started spreading the virus again. And migrant laborers started going back to their places. Again, you can see many of them, huge queues there, infection spread. So we got this second wave. The lockdown created some comfort, but once it's opened up, and especially in the last few weeks, we are seeing a dramatic increase in many of our cities. And part of this is because of these two reasons. But there are also positives. And this is Dharavi slum in Mumbai, the Asia's largest slum where millions of people live. When this virus first came there in March, everybody was worried. They thought the whole slums are going to get completely infected. But the government there got into very severe action, cordoned off the whole of the slum. And what they did was they put contact tracing very effectively. And now, in fact, the lowest incidence of the virus in Bombay is in the slum area because of this effective contact tracing, isolation, and complete sealing of this area. I think this again shows that in India, we can do this, especially even in areas where there's not enough education and so on, but requires a lot of willpower and a lot of dedication by the politicians and officials. The other thing that India started was this Arogya Setu. This was a phone app based on what happened in Korea, in China, and Japan. They thought that probably this would sort of help us to contact trace and isolate. This is now being taken up by some patients, and it's become compulsory when you're traveling in air and so on. But unfortunately, it's not picked up as much as it should. But hopefully, this will help us in future. A lot of innovations coming in this area. One of the other positives about India is the low mortality. In fact, if you look at case fatality rate is 3%, but I believe the true mortality is much, much lower. That is true mortality in terms of millions of per population, the lowest in the world. There's several reasons for this. Maybe it's less than actually 1%. The age of the patient, majority of our people are below 65. Rural population, which is widespread, so they're not getting it as much as in the urban areas. Comorbid conditions, which are much less compared to hypertension or so on in other countries. We have probably an innate immunity because of repeated parasitic infestation. There's a BCG theory which has not been proved now because of studies from Israel. But most important, there's several other factors. And briefly, what we have done, research in our institute has showed that there are mutations in the protease that help to get this virus inside. So in our host body, there are proteases which help the virus, which Talwar and Prem had earlier alluded to. What we have found is that when we did sequencing of these proteases, we found that there are definitive mutations which actually decrease the activity of protease. And this, I think, is very fortunate for Indians because 50% of us seem to have this mutation. There are other problems that have come post-lockdown in addition to the surge that we're seeing. We're seeing a large number of asymptomatic cases. This is, again, very peculiar to India. And I believe this may be partly because of these mutations that we have. ICMR has estimated that 60 to 70% of cases in India are asymptomatic cases. So the reopening of the hospitals has created a problem, especially because we have to protect our healthcare workers. For example, this is typically what happened yesterday in a hospital. 400 cases came to the hospital to see gastroenterologists or cardiologists, not with COVID symptoms. They came. But as a screening process that we did in all of them, and now we screen all the patients for procedures before they go for therapeutic endoscopy and so on. We found that 10%, 40% of them were positive. They didn't come for COVID, they came for other things, which means they're actually asymptomatic carriers. So when we looked at the antibodies in our 400 cases, only 1% had antibody positive, which means we are in a stage with a large number of asymptomatic cases without immunity in the public. And this, I think, is a little dangerous situation for us. So we have to be careful on how we look after our healthcare workers. A lot of measures we put in, we don't have time. But what has changed for us is that now In India, there used to be a lot of conferences. Every week we used to get together, have these meetings, have workshops and so on. This is dramatically changed. Nobody is going. The whole education is now becoming tele-education. Every day we have hundreds of seminars. In fact, we are getting toxic dose of these webinars now in India. And hopefully they'll be moderated to proper extent. We are also changing in terms of telemedicine. Telemedicine was illegal in India till COVID came. And now government has legalized this. I think telemedicine is not a proper way to look after a patient. You still have to see, feel, and see what's happening. But unfortunately, telemedicine is the way we are going about. I think 60 to 70% of our medicine practice now is telemedicine. Coming finally to the treatment aspects, the solidarity trial which WHO has put, which is US is not part, but rest of the world is part, is being now going on very actively. Several randomized controlled trials. Now, going to hydroxychloroquine, I think, again, Dr. Talva pointed out that this is not something that is being used in US. ICMR now recommends, the Indian Council of Medical Research, that we should use it as prophylaxis for healthcare workers, only for healthcare workers. This is based on a randomized controlled trial they did in the All India Institute, where they found that healthcare workers who took hydroxychloroquine once a week were protected. Still not yet published, but this is, again, a little controversial area. So not every healthcare worker is actually taking it because of the toxicity. Hospitalized patients are frequently getting hydroxychloroquine and doxy all over the country. We have been using steroids extensively from very beginning. Usually it was methylprednisolone in ICUs, patients on ventilators, but now of course we have switched to dexamethasone because of recent reports from London. Remdesivir is just coming. The 3 companies in India which have been approved to make this intravenous, and again, I think there's too much hype about this drug. I'm not sure how useful it is. But what is interesting is just yesterday, the Director General of India, the drugs controller of India, has approved favipiravir. Favipiravir was used in Japan initially for normal flu. There's a company, Glenmark, which is now actually made it. In fact, it was not done from the original molecule, but they developed their own pathways. This is now approved now, and it's believed to be useful for mild, moderate cases. There are no good randomized controlled trials. Most of the use has been in Russia, China, and Japan. I think we are now going to start doing randomized controlled trial with this. Unfortunately, I think this is going to be overused drug, because for mild and moderate, we know many of these patients recover. But because of the fear, this drug, which costs about 100 rupees per tablet, has to be taken 3,600 milligrams twice a day first, followed by 800 milligrams twice a day for next 2 weeks, are going to be used, and it's going to be overused in this country. Convalescent plasma has been approved by ICMR. There have been small trials. There's a now randomized controlled trial going on. We have also started using it. And we believe this may be good in addition to monoclonal antibodies when they come. So this is a summary of what is happening about treatment in our country. There's also a huge lay interest in immunity boosters, because this is what everybody is saying. In fact, we have this yoga specialist coming in with different immunity boosters. People are starting to look at this. Vitamin C daily at 500 milligrams, zinc at 60 milligrams, vitamin D at 60,000 units weekly is what is being advocated. And this is especially important for Indian patients, because vitamin D and zinc levels are very low normally. So it's believed that boosting this, and this has been shown, of course, in studies, that boosting this may be helpful. There are others like curcumin and ginger and all tablets coming in, and this is one example of how they're becoming very common, because they don't have side effects, and Indians don't mind using this. So this is, again, something which is different from the rest of the world. I think finally, coming to what this virus has taught us lessons in our country, that no man is an island. I think we all globalize so much that whatever happens in some part of the country rapidly spreads to the other part of the country. It also taught us that nature is supreme, that we have to respect nature, and that we have to follow certain precautions. We don't have definitive treatment. Universal masking, physical distancing, and hand hygiene are the main methods of how we're going to control this. Hopefully, I think Dr. Varaprasad is going to talk about vaccines, and the new normal is going to change only after the vaccines come. Once again, I'd like to thank NATA for giving me this opportunity. Thank you very much.
Thank you very much, Nagi. Thank you for this is very high level, and we have a great command as usual. You give a great talks. You heard many times. So thank you very much. So the next speaker, I think we'll come back to, if you can say, we can come back to the questions as soon as all the speakers are done. So the next speaker is Dr. Varaprasad Reddy Garu. He's the founder of Shanta Biotechnics, named after his mother, his beloved mother. This was the first biotechnology-based vaccine company through totally indigenous technology in India. They produce low-cost and highly effective vaccinations in India. They have donated about 180 million rupees to poor people of India. He had received many awards, including highly coveted Padma Bhushan. Dr. Reddy is the man with first-hand knowledge and experience with vaccinations, and he will talk about COVID-19 vaccinations, when and until then what. That is Dr. Reddy's talk. So Varaprasad Reddy Garu, without further ado, please take over.
Namaskaram Andi. I have heard all the speakers who spoke before me, starting with Dr. Prem Reddy Garu. And I have to compliment them that they have covered extensively on several issues. One of the issue what I wanted to, because I am not a scientist, I am not a doctor, I am an engineer. By providence, I came into healthcare and that too into vaccines. And I had the opportunity to bring recombinant based vaccines into the country for the first time with totally indigenous technology. We didn't depend on any Western source for this technology. So that is a point of pride for our scientists. I am not the scientist. I only made a team of good scientists and they developed it. I was a facilitator. I wanted to address in a different way because all of you are doctors who dealt with the patients and most of you know what is happening around the globe. I want to limit myself on certain aspects, which partly I think Dr. Talwar, with his social conscious, he has covered it. Dr. Nageswara Reddy Garu, wonderfully, he has dealt with all the available treatments and then what is happening in India. He has given the Indian perspective. I am also going to limit myself to Indian perspective, that too, little away from science. What are the things that we should do after this COVID? Before that, I have to say that few aspects about vaccines, what kind of vaccines are there, how they are effective, what are the various vaccine initiatives taken around the globe. I will briefly talk on that. It has taken a toll on lives of many and more than lives, livelihoods. That is very important. If you see the interesting statistical data in the last 3 months, because of COVID, we lost around 400,000 people. But in the same last 3 months, because of flu, around 350,000 people, I am trying to translate into thousands, 350,000 people lost their life. Suicidal deaths are 390,000. Malaria, 400,000. Road accidents, around 400,000. HIV, 240,000. Alcoholic deaths are 560,000. Smoking and TB related, 816,000. With cancer, 1.2 million. So when we compare with other deaths, COVID is not that much, but it has attracted the eye of everybody around the globe because it occurred not in one place, in one state, or in one country. Throughout the world at one go, it has come, and people were shaken up. And many people call it Mahamari, Rakshasi, it is a devil, that and this. In a philosophical way, I feel that it is God sent. It is the 11th avatar of Vishnu to correct our lifestyles, our attitudes to life, our way of running the businesses, our way of living is not correct. It wanted to come and give a correction mode. We have done a lot of damage to environment and we have been very cruel. In 84 lakh species of life, man thought that he is the only supreme and he wanted to eat away everything what is moving. They ate snakes, they ate crabs, everything. Whatever is moving, they started eating it. Ahimsa, it is too much. Mother Earth could not tolerate this, I think. It has sent a correction mechanism, which is very invisible. See what happened to our science, what happened to our so-called, recovery researchers and other things. We are talking about sending a man to moon, but we are not able to solve our own problem in this planet. And we are having major programs to go to send man to Mars for holidays, but we are not able to solve the present problem. It is a pandemic, and which created pandemonium. In my opinion, this is a pandemonium. Governments watching helplessly, and medical professionals are trying tirelessly. Common man is not getting the bharosa, what we call the faith in the system. Many labor, they walked away from the country, from one state to other states. And we have been just watching them, what is happening. See, every other day we get an announcement that hydroxychloroquine is going to help. And other day they say that trials have failed, so stop it. ICMR, WHO, all these institutes are prestigious institutes. They fumbled. They have gone forward and backward. There is no consistent information to the common man, which is very disturbing. So what I want to say is definitely in economic terms, as an entrepreneur, I can say the global economic cost of this virus is whooping $6 to $7 trillion. In India alone, if you see, we are losing in our country every day around $4.5 billion or 32,000 crores every day. That is the economic impact. I told you it cost lives, no doubt, but it has cost a lot of livelihoods. Many people lost their jobs here, and they have become very uncertain. We have around 4.5 million labor force. They are the important pillars of the Indian economy, the construction workers, etc. And they are all on the streets without food. They have been left to lurch, and government could not take any action in right time. So this is the impact of this COVID. And naturally, around the globe, more than 1,000 companies started attempting to make a vaccine. And at least I can say, India also is trying to develop a vaccine with foreign collaborations. You know, any new vaccine to develop in a Western society, it costs them $600 to $800 million to start from ab initio. Okay, in India, the costs are lower. Even if you attempt as a new vaccine, it will cost not less than 100 million, if not 600. But where is the money to put that kind of money? No pharmaceutical company can afford to put so much of money into R&D. In $100 million, no company has ever invested in India. I can honestly say that. But we have definitely taken up vaccines. When other countries, they have done it, we have taken a different route. So vaccine is established with its own process, but we have followed a different process, and we have replicated the vaccine at lower cost. That's a generic. That's what we have been doing. Now, all Indian companies have some collaborative arrangements with other country, vaccine companies around the globe. And a lot of initiatives are there. I will list out. But before that, what other speakers didn't speak about vaccines, there are 5 varieties of vaccines that are being attempted now. First is live attenuated vaccine. Live attenuated vaccines, the pros of it is it is very strong and lasting immunity, but there is a risk of reversion to virulence. So that is also being tried. For example, polio vaccine. Oral polio is a live attenuated vaccine. There was a cure to some extent, but unfortunately, some people got affected by it also. So it's not well accepted, but people are trying to do that. And killed vaccine is there. No risk of virulence, less immunogenic than live vaccine. Other is recently very popularized vaccine is recombinant protein vaccine, what Shanta attempted to do it around 92. And the first recombinant vaccine came in the form of hepatitis B vaccine. These are totally indigenous. And this can be targeted to the key protein of the virus. Now they call it S1 protein. It can be easily targeted to that, and it's a very appropriate kind of vaccine. It is being attempted by many companies, but it has one weakness. With adjuvant only, it can be highly immunogenic. Without adjuvant, we have to give more dosage, so we can't cover more people. If adjuvant is added to it, then definitely it will be more effective. Then there is a DNA vaccine. It's very easy and inexpensive, very faster to develop, and potential for lasting immunity, and no need of cold chain. So DNA vaccine has wonderful positives. But the problem is potential for genomic integration. It can integrate with the human genome and allergic to DNA. And there is best vaccine is mRNA vaccine. That is also being tried out now. It's very easy, inexpensive, faster to make, potential for lasting immunity, and no need of cold chain, and also no risk of genomic integration. But the problem is, so far it is unproven technology. There is no mRNA vaccine in the market. If it is going to be done for COVID, it will be the first one to come into the market. So this is the 5 varieties of vaccines, and many companies are trying all the 5. But at least from my side, I have to say, Shanta is now part of Sanofi. Sanofi has taken major stock into Shanta. As a promoter and founder of that company, Shanta, I remain as a shareholder, but Sanofi is a major shareholder. The R&D, what they are doing, you have to understand very interesting aspect here in this unprecedented times of emergency. 2 rival companies, major giants in vaccines, GSK and Sanofi, they are contenders in the market for market share. They never saw eye to eye on many issues and when it is coming to business. But in this kind of emergency situation, they have come together. They have joined hands together. Of course, I should not say hands. No, we cannot join hands in these COVID times. And they came to an agreement that they want to develop a vaccine jointly. And they have been funded by American government. They have given to Sanofi $675 million to come out with a vaccine, a recombinant-based vaccine. They have joined with GSK for the purpose of getting adjuvant, appropriate adjuvant from GSK. GSK is very strong in adjuvants, and Sanofi is very strong in recombinant technology. They are coming together to get an effective vaccine. They are in phase 2 trials now. Probably, in all probability, by next year, 2021, middle of 21, they will transfer the technology to Indian fit for Shanta Biotech. And Shanta is preparing themselves to produce this vaccine cost effectively in high volumes at low cost. That is the philosophy of Shanta. Make it available in local currency, make it affordable. So in all probability, Shanta will start producing next year, September onwards, not before that. And many people in India making statements very loosely. Vaccine is coming next month, vaccine coming in 15 days, 20 days, which is very wrong. Based on this, our political leaders are taking a call on lockdowns, and very bad. The wrong information, misinformation, this disinformation is very dangerous to society. And based on that, political leaders are taking a call whether to keep the lockdown or lift the lockdown, or lifting the lockdown with some conditions, etc. The real fact is the vaccine is not that easy to come. It takes minimum 18 months to 2 years. Even if regulatory agency coming forward to have some concessions in the testing process. See, compared to a drug, vaccines take long time because of its testing process. It has to be tested at several stages of development. They have IBSC committee, Institutional Biosafety Committee. Then they have RCGM, Review Committee on Genetic Manipulation. They have Genetic Engineering and Application Committee. And after that, Drug Control General of India, DCGI. And also, at every stage, they have to get a clearance. It's not that easy. You know, bureaucratic delays. Science delays are some part, bureaucratic delays are other part. They have to have discussed this in the committees, and committees that they are not formed that easily. Even if the committee is formed, the quorum is not complete with a lot of absence. And after the committee is met and then taken a decision, the minutes are not well prepared in time and they are not circulated, it's not approved. So, you know, the process is very long, 18 months minimum. And 2 years is normal. But other vaccines, what we developed earlier were 4 years to 5 years. In this emergency situation, DCGI is coming forward. Even USFDA has given fast-track clearances. For example, Remdesivir, they have agreed to use it, but again, they have backtracked. Now, Remdesivir, please stop it, they have given indication. So it's the case with hydroxychloroquine. What I'm trying to say is, in this pandemic situation, a lot of pandemonium has occurred, both from institutions, from political leaders. Doctors are tirelessly working, but they are also confused what kind of treatment should go on and what should not be. Now, there is some clarity. Now, India, recently, yesterday, day before yesterday, Friday, they have given the clearance for a medicine, a tablet, Favipia, they call it Fabiflu. Probably that will give some what you call confidence in the people. But as Dr. Nageswara said, rightly said, it may be overused or abused. It should be there with some control. People, they have the herd mentality. If they hear something, they go all along on that. That is very dangerous. And now I have to say, the different vaccines are in which stage. I told you 5 varieties of vaccines. In my, the other important information what we should do is, Oxford University, they have conducted animal trials at one go. The trials were not successful. They stopped it. But again, I don't know how far it is true. Their counterpart in India, I mean, they have transferred this technology. They are trying to transfer the technology to Serum Institute. They say that they are ready with 2 million doses of vaccine, even without trials completed. How they can produce a vaccine and how they are waiting for the clearance, I have no idea. But these are called misinformations, or nonsensical informations. But people are being fed with this kind of information by media. Media is very active. They have nothing but showing only COVID data, only this kind of information. They announced that Oxford University vaccine is ready to be transferred to Serum Institute. They are coming out. They say that they have already produced 2 million and waiting for the clearance. But 2 million is not enough. They have to produce thousands of millions of doses. Next, US firm Moderna completed phase 2 trials. Phase 3 trials, it will enroll 30,000 participants and trials will begin next month, they said. That means it's not yet ready. But Trump announced on 6th June, 2 million vaccines are already produced and efficacy is also proved, then they will be administered. We do not know whether he had Moderna in mind, and one wonders why anyone would produce 2 million doses even before its safety is established. There is a news that vaccines are in pipeline in Australia, Israel, and also in other countries. Russia too claimed that they have vaccine. They are producing it by 2021. US company Vaccine is working on University of Georgia. Then they are saying that they are in the first phase of human trials, and they will commence soon for phase 2. Then India, we have 6 companies, vaccine companies, and all of us have some connection with the outside development agency. Shanta, I told you, with Sanofi, and Bharat Biotech with Wisconsin University, Serum Institute with Oxford University. On 25th May, 25th May, Dr. Harshvardhan, our Central Health Minister, he said that 14 vaccines are in development. I don't know. There are only 6 companies, but how 14 numbers have come? These are the misinformations. What I am trying to say is, in this kind of pandemic situations, people should speak truth when they know the truth. When they do not know, I think they should not give this kind of wrong information. Indian government donated $15 million to Gavi Institute, the Gavi, International Institute. Their purpose and mission is to develop vaccines. On June 5th, they have donated. It indicates that the government is not very optimistic about indigenous efforts. Otherwise, they would have given that money to Indian companies. You should know the Indian situation. I'm giving the Indian perspective. The defense budget in this country is 4,71,000 crores. And for health, it is 69,000 crores. Where is 4,71,000? Where is 69,000? They don't respect health in this country. And also for education, 99,000 crores. I think they should change their priority. They should revisit their budget allocations. Health is more important. LOC, enough control is important, I agree. If they lose 1 foot of land, they are so much worried, they are investing billions of dollars in defense budget. Is it not important a man's life? Desamante Mattikavai, Desamante Manushoi. That is the thing what we learned in our childhood. But now, for 1 foot of land, they want to spend billions of dollars. For health, they don't spend. Are we not losing people? So they should revisit, government should understand the future wars are not going to be by military aircraft or submarines. It's going to be life, these kind of weapons, what you call Jivasanketika Ayudhalu. These are the kind of invasions will occur. Probably even this virus also is man-made. That's what some people, even Trump is talking like that. I believe in that. It is all man-made, not anything which is coming from nature. Nature is not that cruel. But we also are doing very cruel to nature, and nature might have come in this way to give us a lesson to reform ourselves, to correct ourselves. And I want to speak 6 or 7 points for the future.
Maybe, okay. Yeah, please do 5 minutes. Maybe you can go 5 minutes.
Yes, I will close in 4 or 5 minutes.
Yeah, okay.
Lessons for the future. Let all the countries in the world understand that public health is government's responsibility. It cannot be in private. And they need to strengthen government hospitals. Let governments give priority to medical education, practice, and research. Let governments spend money on education, on public cost, so that people would realize the importance of hygiene and sanitation. Create jobs in rural areas. Don't everything come to only cities and metropolitans. Create jobs in rural areas. Discourage urbanization. See that urban slums are not formed, lest they become hotbeds of epidemic. Let there be epidemic centers for each district headquarters. Discourage mass gatherings, decentralized development for better management. Let there be doorstep volunteer system to monitor public health and help the need at the hour of crisis. Let us change our lifestyles, eat fresh, healthy food, maintain personal hygiene, improve our immunity, avoid restaurants. My advice to Dr. Kiran, but I'm already in the restaurant, Kiran Patel, restaurants are not to be encouraged anymore. Let us develop more and more vaccines to boost our immunity against viruses. Let the experts not mislead public with half knowledge. Let them be sure of themselves before declaring something. Last but not least, let us elect those leaders who have some understanding about scientific issues. Let us not be swayed away by theatrical performances by demagogues. I hope you understand how our political leaders are talking about COVID. They are all demagogues. Thank you very much.
Thank you for your talk, and it is passionate and from his heart, very from his heart and sincere talk. Anyway, we are short of time, that's why we have to move on. So I understand that Dr. Suresh Reddy has to leave. So can you say two minutes, Suresh? Can you talk? He's president of API. He has conflicting events going on with API. So I think maybe he has left already, I suppose, but okay. Thank you very much, Varaprasad Reddy Garu. Thank you for your talk. It was great talk and sincere talk. Okay, the next, we were going to talk about this vaccination from US perspective. So Dr. Arunab Talwar.
I think it should continue. He covered it well, and I think to be fair for other speakers, I'm going to skip my talk and let others do it because we're getting late. And I can come back for during question time if there's anything. He covered it very well. So let's just continue with other speakers to be fair to them.
Appreciate it, Talwar Arnab. Thank you very much. Appreciate it. But maybe you can say a few words at the end then after Kavita and also Dr. G. Reddy Prasad is done.
Suresh Reddy Garu is there.
I thought Suresh Reddy didn't respond when I asked him. He had to leave, I think. Suresh, are you?
Yeah, I'm back. Yes, sorry.
Yeah.
Okay.
I'm running 3 Zooms at the same
according
time.
To schedule, Kavita is supposed to go, but can you talk for about 2 minutes, Suresh?
Okay, yeah, thank you. I'm running 3 Zooms at the same time, so I'm jumping into 3 different rooms. I'm so sorry. Happy, thank you. All my mentors are here. My role models are here. Dr. Prem Reddy Garu, Varaprasad Reddy Garu, Nagesh Reddy Garu, Mohan Mallam, all Prasad Ji Reddy Garu. Thank you so much for joining, and friends. I'll keep it very short. API, this has been, this year we started with our main goals were 2 main public education events. Those are obesity prevention and CPR training. And we have completed CPR training in 7 continents, including Antarctica and South America. And the same thing, obesity awareness. Obesity awareness, as you know, has been diagnosed as a disease now. And when the COVID came, suddenly all our priorities changed. Overnight, as you know, the doctors have to become soldiers with not proper training. We are never trained to see hundreds and hundreds of deaths in a single day. And psychologically, they are affected. And even protective equipment was not adequate. The machinery was not adequate. And our soldiers had to go into the war without proper equipment, but they did it. And now we are able to control it. And we have done several programs. We have done mass public education. We have released press releases, and we are the first ones. The RP, as the first organization in the country, has called for a total lockdown in the country, universal mask wearing, and first plasma treatment, and steroids. And these are all the public education policies we did. And then coming to medical education, we organized more than 50 webinars. That's the education for the physicians and non-physicians. And we also raised the importance of physical hygiene and hand washing. And over that, we also did several mentoring for medical students and residents. And coming to research, we started some research projects, like how looks like Indians have more resistance to this than the Americans here. And also we are doing research projects on the plasma treatment. We are doing research projects on yoga along with our RP members with the Isha Foundation. Several research projects going on. We also did several charity. We raised significant amount of money to provide protective equipment in a lot of county hospitals where there are severe shortage. And recently with the Nurses Week, we honored 10,000 nurses with providing lunches in over 37 states in the country, including Alaska and Hawaii. And we provided more than 1,000 online prescriptions for visitors coming from India because they were stranded here, especially the parents and students who did not have insurance. Our physicians went beyond the call of duty and worked with the Indian Embassy, and we provided more than 1,000 online prescriptions crossing the state lines. And we did several of these events, and hopefully, as you know, several of our own physicians became positive, some of them critically ill, and a few of them even died from this deadly disease. Thank you so much for giving me this opportunity, and we are very proud. As you know, like every 7th physician in the United States is an Indian physician, and we are at the forefront, and I'm very proud of them. And thank you all my mentors and role models here and friends for supporting this organization. Thank you.
Thank you, Suresh. Thank you very much. So if you have to excuse yourself, that's fine. But if you want to say for questions, it's your call.
I will join you later. I had to go run another Zoom session.
Thank you.
Thank you so much.
That's fine. Thank you very much. Okay, so moving on. So Dr. Kavita Reddy is the next speaker. Dr. Kavita Reddy is the rising star who is an emergency room physician and integrative medicine specialist. Dr. Reddy is the incoming director of employee whole health of the Veterans Administration of the whole United States. The key word here is the whole health. And Dr. Kavita Reddy is going to talk about future of healthcare delivery and how you can improve your own health. This is a very timely topic, and also it's very useful for all of us and your families. So we welcome Kavita to go ahead and talk about it, enlighten us with what we should be doing. Thank you.
Great, thank you so much. If that's okay, we can go to the next slide. Okay, so we decided to really end with this piece of information to all of you because this really is a time for us to stop and look at what our healthcare system is within the United States and how we care for our people and individuals. It's an opportunity for us to assess how we're not only responding to patients, but how we're responding for ourselves, for our own self-care. And so COVID-19 reminds us really of the need to look at our physical and mental health. I think it's been beautifully stated by a lot of the speakers already. COVID-19 is one piece of the equation, a very important piece of the equation, but look at all of the resulting effects this is having on everybody. from social isolation to a change in how we deliver care, not just healthcare, all businesses, some shutting down, some doing things virtually, many of us having to care for our own children at home and become teachers in addition to our jobs and other focuses. The stress levels are actually heightening quite a bit. And you couple that with this idea of we don't exactly know when the treatments will come. We don't exactly know when a vaccine will come. It leaves us in a state of not feeling in control. And when you lose that sense of control over what's happening in your life in the moment, that's when you start to get feelings of anxiety and stress, and it can significantly affect mental health. And so I think it's really important for us to stop and understand, how do we not only deal with this public health crisis, but in the midst of this, as Dr. Varaprasad is saying, there are other crises going on. We're looking at a system of social inequality, healthcare disparities, environmental issues. You know, as we start to have a growing population in the world, our proximity next to environmental areas that we never used to be around might expose us to pathogens that we usually, our systems are not used to. So again, how do we look at the climate, the world, the people, the social inequalities? All of that is wrapped up into COVID-19. The awareness of all of this is a part of that. And so within the VA system, we are really on the forefront of transitioning healthcare to a whole health system of care. As you guys hear some of my thoughts, you'll maybe recognize some of these whole health models that have been out there for a while, maybe even see elements of Ayurveda in this. But the idea is that we can't just be treating the symptoms and diseases. We have to be looking at the entire person, the whole person, mind, body, and spirit. If you actually look at the CDC and the AMA, they've been emphasizing methods to reduce stress and anxiety related to this pandemic. They are seeing an opportunity to address not only the burnout of healthcare providers, but the burnout of all individuals in general. And I highly recommend you checking out their websites to see some of the recommendations they have. And then I really want to drive home this point that hasn't been mentioned yet. We talk a lot about COVID's impact on certain demographics, populations, and races, with the preponderance of people with diabetes and obesity really succumbing to COVID-19 and having the brunt of the mortality rate. But that isn't just COVID-19. This really should open our eyes to the fact that our healthcare system has things that can be fixed. It has issues with how it delivers care and to whom it delivers care. So the issue is, these are people that historically haven't had the greatest access to health literacy, to health care, to resources, interventions. And so I really should open our eyes to saying, how can we improve the very system that delivers care so that chronic disease and illness is actually what we're looking at and treating. And that then would help other diseases that come down the road. So we can go to the next slide. So what I want to share with you is what we're doing in the VA system. But for all of you out there, whether you're a healthcare provider or not, this is something I want you to take home and think about. In our lives, these are the things that matter to us. These are the elements that help us live our healthy and well-being lifestyle. And when one of these is out of balance, we lose that balance for our own wellness. You might recognize that many of these are the social determinants of health, how we have relationships, our surroundings, our sleep, our access to food or lack of access to food, and our resilience or our power of the mind. And what I really want to stress is that we have the power to actually improve our immune system. It is an innate healing process within us. And while we wait for the right medications, while we wait for the right vaccines, we should not really lose the opportunity to think about how we can help ourselves in this very moment. And so when we think about psychological stress, which many of us are feeling right now, many of the healthcare workers have expressed that this is a daunting, scary time for them. And as an emergency medicine physician, I can tell you, when I work my shifts, it's time 0. And then I count the days to know whether I'm actually going to get sick or not sick. So that stress is actually disrupting the immune system and is associated with pro-inflammatory cytokines. And we know COVID is connected to an inflammatory process. When gone awry, it can actually create much of the mortality, as you've heard. And then sleep. Shorter sleep is actually connected to an increased risk of infection. Actually, studies have shown that under 5 hours of sleep can be connected to a 350% increase in rhinovirus. And sleep deprivation may decrease the amount of melatonin that's secreted. And melatonin is very key to immune system and sleep, actually lowers as we age. And there's some thinking that maybe that's what the correlation is between certain demographics and populations of elderly folks getting more sick. And then nutrition. This is something that's near and dear to my heart. Not something we were trained very well in medical school, but something I have learned an immense amount in my integrative medicine training. Food can be therapy. And as we think about inflammation, what we eat on a day-to-day basis has an impact. So of course, your vegetables and fruits that are high in flavonoids are going to be anti-inflammatory. When you think about things like zinc or ionophores that help increase the absorption of zinc, like onions, apples that have quercetin, or ECGC in green tea, there are actual foods that help us create a low inflammatory response in the body. And these are things we can do right now. Each one of these areas is an area that we can optimize. And as we think about the future of healthcare delivery, this is really how we help people mitigate disease and pain and chronic mental health illness, by walking this circle and understanding how to really balance each section. So we can go to the next slide, and I'll share a little bit about what VA is doing. Telemedicine has been here and present in the United States for quite some time, but not in the degree it is now. In the last 3 months, we have had an astronomical increase in virtual care. It really is the future of healthcare delivery, because if the future is based on health and well-being, that can absolutely be delivered in a virtual world. If you think about social isolation, we know that's connected to depression, lower lifespan, and a lot of other disease processes. And telemedicine, virtual care allows us to access people in their home, allows us to improve their health literacy, can impact some of those social determinants and healthcare disparities that we see. You heard people mentioning complementary and integrative health. It's actually mandated within our VA system to offer many of these approaches given the level of evidence. Yoga, meditation can be immensely helpful with depression, anxiety, stress, and pain. And so we offer all of these. You see pictures of how we offer this virtually, and we have websites that allow people to tap into this knowledge from their own home. There's no reason you can't continue this type of care, even when we can't come into the hospitals. Next slide. What we have done here and is accessible to all of you, and really, again, my final thoughts for you is that we have to emphasize self-care. And as clinicians, this is really important, but this is important for everybody. We have to take this moment to understand that what we are feeling from COVID-19, the mental health, the physical health, the fear, all of that we need to address through self-care resources. This site is actually accessible to all of you. It's put together through multiple different stakeholders within VA. And as you can see, really tries to address resiliency, spiritual health, mind health, physical health. And they're easy to listen to podcasts or videos that you can do in your car, in your day, but injecting those into your day-to-day function will help you with some of the stress that's coming forward from this disease process. And so I really highly encourage you to look at that. But I just want to leave with saying this. I have a huge degree of optimism that COVID-19 is highlighting a lot of different political, environmental, healthcare, and economic systems that we can improve so that we can face these kinds of challenges with much more vigor in the future. So with that, I'll turn it back to you, Dr. Adireddy. Thank you so much.
Thank you very much, Kavita. It is a superb but futuristic talk. I think we should all be following her advice and try to prevent the COVID and other infections or reduce the mortality. Thank you very much. So next is we have questions and answers. So hopefully we can extend by another half an hour.
That's not a problem, Andy.
Okay, yeah. Thank you. So next is we have Dr. G. Reddy Prasad. So that we're done with Dr. G. Reddy Prasad. So we want him to give about 5-minute response. So basically, Dr. G. Reddy Prasad is a very respected endocrinologist and a serial entrepreneur. His current passion and research and entrepreneurial activity is about artificial intelligence. And he's the head of a 200 physician member group of Pomona, California. We have a specific question for him. The food that goes inside the mouth is as important as the mask that goes over the mouth. So the mortality of COVID-19 is higher in patients with obesity and diabetes. So what should people do to curb these ailments? Dr. G. Reddy, go ahead.
Well, very tough question, but anyway, we had such a Endaro Mahanubhav, elite speakers were there, and Varaprasad Reddy has already told you about the diet. So you're already obese, you unfortunately you can't reverse it quickly. And this quick snapshot of diabetes, we have about 34.2 million people in the United States have type 2 diabetes. Almost 1 in 5 don't even know that they have diabetes. And you have almost 88 million people are there, what we call as impaired fasting glucose, or simplistic term, pre-diabetes. So this is additional risk factor. And Dr. Kavita also mentioned about food and right habits and good habits. All this will play into effect with the prevention of our maybe postponement of development of diabetes with obese people with the reduce the weight and be active. Simplistic solutions for this at least is you basically lose weight, eat right, be active. There's 3 different things which we need to do. But the topic of COVID-19, just like Varaprasad Reddy said, 11th avatar came and trying to change all your habits and things like that. Something is coming out. So my input for this is especially some of these hospitalized diabetic patients, you're using high doses of steroids, and it does pose a problem. And hospitalized, even on an outpatient basis, important part is glycemic control for people who non-physicians, like sugar control, keep them in the normal range. That decreases the risk of developing infections. As usual, diabetics do have increased incidence of, decreased immunity, increased incidence of infections, and they have associated comorbid conditions like hypertension and vascular disease. And there's one, if at all I have to see a little light or the silver lining, people, diabetics use ACE inhibitors, which blocks some of those. Prem showed in his slides, this COVID virus attaches to itself a receptor. That receptor is actually occupied by ACE inhibitors, which we commonly use in diabetics. Hopefully that will reduce the complication. We don't know that yet. So my quick and simplistic thing is somebody on oral agents like metformin or something called SGLT2 inhibitors like Jardiance or Invokana. Got to be a little careful with this because the intake of fluids and people may become problematic. And so insulin really raises a very strong necessity, long and short acting insulin, especially hospitalized patients. Other than that, really, I would keep myself open for any questions because this is a vast subject. So, everybody covered all aspects of at least whatever we know at this time. So I'll keep myself available for any questions regarding interventions and what need to be done. And a lot of things came in diabetes for the last 40 years. Anyway, so I'll stop there. So you have plenty of time for questions and I'll be available for any questions.
Yeah, thank you. Thank you, G. Reddy Garu. Thank you very much. Yeah, I think we got one question from the online. So we have some prepared questions. So we'll go ahead and maybe you can make the brief answer, like a brief response. That way multiple faculty or multiple panel can respond. So one question I have is, there are 3, 4, 5 companies or major companies are trying for vaccination. So let's say this vaccination is available in phase 3 or phase 2 trial. So Dr. Talwar or Dr. Varaprasad Reddy or Prem or anyone, if all 5 companies are available at the same time, which one would you go with? Dr. Talwar, you can answer. Phase 2 or Dr. Varaprasad Reddy? Phase 2 or phase 3? Which one would you pick? You have 5 choices. So which Moderna or GSK or AstraZeneca, which one would you go with?
That looks like a question more for a stock market than this.
Yeah, but lives are at stake, so people are willing to get the vaccination. So
yes, let me see if I can answer this question in a scientific way for you. Though Dr. Reddy did an incredible job. He's not even a physician, but I really enjoyed his talk because he gave a very nice view of the whole thing.
Yeah.
But let me see if I can get this. I don't know if this slide goes up. Is this slide being presented? No. The way it looks like as of now, and he has shown, Dr. Reddy pointed that out. This is an RNA virus. And its infectivity and the way its strain is behaving is not, we have not dealt with this before. So of the 5, he said, there were actually 8 ways of making a virus, of making the vaccination. I believe the RNA virus would be the one, and that would probably hit the market. But I also want to point out, more from clinical point of view, we would need more than one virus, more than one vaccine for this condition. One vaccine will not fit size, will fit everybody's requirements. We would need more than one effective vaccination to control this condition. I do want to point out a little bit about mutation and strain. And a common people generally confuse the two as if they are interchangeable. No, viruses mutate all the time. And this virus, a part of the RNA, is mutating all the time. Is it changing as a strain big enough? That is not clear. But still, because of it, and this was pointed out before as well from Dr. Reddy from Hyderabad as well, because of this, maybe we would need 2 or 3 types of viruses. As of now, to me, the Moderna effect, because it's new, it's novel, and they have ramped up their platform so much that they seem to be ahead of the curve, at least in United States point of view. But I also like the GSK and Sanofi Pharmaceuticals approach. Why? I would, if I had to put my thought and effort behind it, they make more sense to me, because and Dr. Reddy pointed it out, GSK has the adjuvant technology. They by far are the best in that. And Sanofi has the rest of the technology. If they put together, I think they have a great chance of coming ahead of this. The Oxford and the Pune Institute one, the details are not available at this point of time. So I would not like to say anything much on it, because one is not available for scientific community to preview. It's hard to conjecturize. And as we know from this condition, we really can't just take things for granted and hypothesize this will be or that will be. So to me, it's the adjuvant technology with the recombinant technology of Sanofi that makes sense from the traditional pathway, and the new pathway of Moderna does appear effective at this point of time. We would know the results at least in 2-3 months from them, maybe by August, and to see where they are at this point of time. I hope I answered your question in this.
Yeah, that's great answer. Great answer. So, Varaprasad Reddy garu, cheppandi. Go ahead. Oh, you are on mute. Mute, Varaprasad Reddy. Unmute.
Dr. Talwar Saab, he has explained very well how the combination is going to be more effective, and also Moderna vaccine. But there are other factors which will determine the choice of vaccine. First is, we do not have clinical data. No company puts it across to public domain. We don't know what is their immunogenicity, what is their efficacy. Okay, safety is established. That's why they could move from animal trials to human trials. That is established. But how about efficacy? Did they ever publish any data? Nothing. Second thing is, how long the immunogenicity lasts. That is also important. That can be known only after several tests, and they have to keep it on shelf how long. This also determines whether this vaccine is acceptable or not. Suppose the immunogenicity lasts only for 1 month or 2 months or 1 year, then is it worth taking? The immunogenicity should last at least for 3 to 4 years or 5 years. And nobody has ever come across with the data. How to choose a vaccine? If I take this vaccine, if it gives me protection for at least 1 year, then I intend to take it. Suppose it's not established, I don't know whether to take that vaccine or not.
This is a clinical trial, right? This is a clinical trial.
These are trials. All are in trials. We can't. This is the problem.
Yeah.
During the trial period, they don't announce anything. Only regulators come to know about it.
Yeah.
When they give approval, then we have to choose. As you correctly said.
No, I'm talking about this time. At this time, which trial, if you have access to, you are a patient and you are a subject, which trial would you accept, So safety-wise, you are saying that safety-wise, all of these drugs are safe at this point.
mRNA is also safe, but it is not yet, so far, no vaccine available. First time it is coming. So natural fear is there in that. Recombinant is well established.
Yes.
Okay.
I also want
mRNA vaccine is faster to do, easy to do, low cost, and it has no virulence problem. Yes. A lot of advantages are there.
But I also believe that I think there won't be one vaccine which would just give you lifelong immunity. Knowing this virus, I think it would be repeated exposure. Look at influenza virus. We have had it for 100 years. We still have to take it every day, every year. Correct. Coronaviruses, sir, it's going to be the same way. Probably every 2 years or something like that, but it won't be like one lifetime. You take it and you're done for it. That time is gone.
Yeah, I understand. Yeah. That's correct. That's good. Okay. So one quick answer, quick question. Transmission by asymptomatic people. How risky is that? Asymptomatic people. Just a brief answer.
I think there's been a lot of debate in the literature because the WHO initially said it's a common mode, but then again came back and said that it's not a problem at all. But I think it is a problem. Asymptomatic carriers do spread the disease, because it's difficult to distinguish between asymptomatic carriers and pre-symptomatic stage. That's the problem. And in India, at least now we are going to see, because the family spread seems to be through asymptomatic carriers. The only positive thing about it is if somebody is asymptomatic carrier, the amount of density of virus transmitted seems to be less than an infected person. So the person who's catching it seems to have less than what normally happens. And just briefly about the previous one, the only published article on the vaccine has been in Lancet 2 weeks back from a Chinese company, Sinovac, which has published their phase 1 trial showing safety and efficacy of this vaccine. Of course, like all Chinese data, I think people are starting to look at it critically, but that's the only published article we have on the vaccine.
I do want to point out for the asymptomatic, just think of this way. The younger the age, more chances of the person having asymptomatic infection. And as you age further, more chances of you having symptomatic infection. Obviously, the bolus, the distance, and the age. So think of the triangle: the bolus of the virus, the age of the person, and the distance when you person who was coughing or sneezing or anything, and how far you were away from it. These three things determine, but age helps people. Younger population does have high chances of having asymptomatic infection.
And one comment I'll make also.
Let me give a light, Adi.
Yeah.
Okay. Let me give a light-hearted answer.
Okay.
Let's wait and see for next 2 weeks how the 50,000 people in Tulsa, Oklahoma, who are asymptomatic that went there and they were tested for apparently for temperature, and see how it evolves. So that will be epidemiological study within 2 weeks.
Right. Yeah, already 6 of them got infected. So I think Trump is going to be for a rude awakening in that one. I feel like.
We'll see.
I want to make one comment too, because I think this is really important what you guys are talking about, because the WHO came out not too long ago saying there was no asymptomatic transmission. So I see this is the kind of information that starts to confuse people out there. And I really want to stress that, that's inaccurate. We've actually, initially it was quoted at 18%, and then it was quoted at 44%. And so while we don't exactly know the exact percentage, to think that you're not capable of transmitting it is spreading false information. And so the need for masking, which has been proven to be effective from spreading, is really critical. So I just want to underline that point.
Yeah, I appreciate it. That's good comment. Yeah, so I think there are some more questions that we have. So at the last, I think we are time-wise, we are not in a rush. I think we're all enthusiastic. So I want you all these faculty, the speakers give like a 1-sentence answer at the end, at the end, each one give 1 sentence. What is the take-home message today after the meeting? So in the meantime, let me ask one more question here. The second surge in October or fall, what are your thoughts about second surge and what we should be doing about it? Anyone?
The second surge would not be as severe as we saw that in New York. It won't be as severe in anywhere else for many reasons. But from an epidemiology point of view, if you look at the virus has already affected the easy host. Easy host means in the first time around, people who were very easily susceptible, the nursing home patients, the elderly population, diabetics, obese, who had more comorbidities, the first time around it already got it. Secondly, with the first infection, you start building a little bit of herd immunity. So, and thirdly, people have learned a little bit more a lesson. So they at least today are a little bit more abiding to the social distancing and other effects. So general public starts to learn a little bit about it. So hopefully the second surge that will come will not be that severe. We also know now to take care of the very sick people, more patients with ARDS, etc. And hopefully some other medications will be available by September. Why will it be more difficult to diagnose this condition? Because that in at least is also the time when the general flu epidemic starts. So for a primary care physician or physician in a community, it will be very difficult. Anybody who has a little bit cough, running nose, and this, is it flu or is it COVID? So the workload of the physician, primary care physician and the frontline workers is going to increase. The severity of the disease, the way it hit New York and the way it hit some parts of the Italy and other parts of the country would not be that much. I think we've already seen that we have learned how to manage the ICU patients better. The mortality in the ICU is stabilizing and it is going down. So that's a good news of this.
Okay. Yeah, Nagi, is there any comment on that? Or yeah,
no, I think I agree with.
Yeah. Okay. Yeah. Okay. Thanks. And Nagi, one more question from GS standpoint. The COVID can cause diarrhea. About 30% of patients can have diarrhea. But what I understand is that infectivity from the stool is low. So is that your experience, or what do you think?
So when actually we started discovering that stool has got this virus, there was a belief that this could be a fecal-oral transmission. But fortunately, this has not been demonstrated. In fact, the only thing that we have seen is that those patients who have gastrointestinal diseases have more severe prognosis. That is, they tend to get more into severe cases or critical cases compared to those who don't have gastrointestinal disease. Yes. This may be partly because of the viral load, which is more in these people. We're not very sure. But the transmission, there's no evidence of a fecal-oral transmission. But one very important thing that is coming up recently is that if you actually look at sewage systems and start looking at the virus presence in this, you can trace the epidemiology of the disease. And just recently, it was found that in Italy, for example, that this virus was present even in November, December in the sewage, in the water systems. So they check the water system. So this is becoming a very important epidemiological tool for epidemiologists to look at the sewage systems to find out. But right now, we don't have evidence that there's a fecal-oral transmission, but I think we have to be careful.
Okay, thank you. Okay, so this other question I have is Prem and others, the telehealth. What are some of the creative and unique ways of using telehealth going forward? I think Prem and Nageshwar and Kavita, at least three of them can answer, and the others also can join. So what are some of the creative ways of using the telehealth?
Nageshwar.
Pardon?
Nageshwar first.
Okay. Yeah.
So my take on telehealth is I'm very old-fashioned. I think we still have to see our patients, feel them, and then we're actually looking just at how a patient walks into your clinic, you can often make a diagnosis. Telehealth is very limited way. Unfortunately, we don't have anything at this point of time. I think telehealth is going to, in my opinion, at least in India, is going to last only till this pandemic. And once the pandemic goes off, telehealth is going to slowly go, except for remote areas with no accessibility. We have been doing a lot of telehealth. In fact, we created large vans which go into villages. We even do endoscopy, telehealth, get transmissions and all. But in my opinion, telehealth is only a temporary phenomenon at present. We have to see our patients. Only then, I think the patient is satisfied, the physician is satisfied, and optimum therapy. That's my take.
Kavita, your comments?
Yeah. Can I doubt Prasad?
Yeah,
So the telehealth, just like Dr. Nageshwar said, we're all You need to feel the patient, touch them to see their reaction. Especially in my field of endocrinology, in spite of seeing them, sometimes I can't even make a diagnosis. And by this telehealth looks like some kind of voodoo medicine temporarily at this time. You know, it has a role. Now, because of this virus fear, is fine. I'm not denying there's a role. I think is that we have to see our patients. You know, you just can't do by phone. And even by seeing, I sent a lot of patients with all kinds of symptoms, hormonal effects, and all kinds of stuff. And you can't make a diagnosis in these kind of guys. Anyway, that's my opinion.
So,
Dr. Kavita.
Yeah, I have a sort of a contrary opinion, I think, to that. So, you know, access to healthcare is a huge piece of this. And so the ability to do group visits, the ability to reach people who normally have difficulty with transportation, it's really actually critical. And while it's I'm not negating that you have to see the person for the right physical exam and the right illness, there's a lot of follow-up care that happens in between seeing people that can be done through telemedicine. And the right technology is very important to being able to communicate well. The other piece of that is that, you know, we've actually seen no-show rates going down, productivity going up, and the ability to actually help people with their medications, their environment, their health education. So it's not going anywhere. In fact, it's something that our patients are quite happy with in the VA system. So maybe with time, it's a technology people will grow to use more. Okay,
my comments on that. Oh, something else came. Could everybody hear me?
Yes.
Yeah.
Okay. So my comment, I agree with Dr. Kavita, because my daughter Kavita and my son-in-law Sunny are gung-ho about this telemedicine. The rationale is somewhat strange. Okay, first of all, you get paid now in America. Okay, we weren't getting paid for telemedicine before. And surprisingly, it's equal payment. It's the same as you were to see the patient. So like Kavita said, you know, there'll be in the primary care setting, especially the two aspects of it. With the primary care, especially now, it's very difficult to see the patients, and volumes plummeted in physician offices. So one, for keeping your overhead costs, the only way you could do that is through telehealth and getting paid. So it's good medicine and good reimbursement. The other aspect also, leaving alone primary health, the telemedicine that we are promoting all across our hospitals is mainly in neurology and psychiatry. Okay, in neurology, it's very hard to get a neurologist in a community hospital of 100 beds, especially when the hospital is isolated. And what is happening is that the EMS or paramedics do not want to take you to the hospital that doesn't have a stroke. And you end up losing all those patients, even though it is farther away. So it is not good medicine, except for the way that stroke centers have promoted themselves as those panacea. So for hospitals, telemedicine has become a book boom. And like Kavita said about VA, we do, two hospitals, we do a lot of prison patients. And that is so helpful in prison patients, because to bring a prisoner to a hospital, you need 2 guards. And so they have to load up at 5 o'clock in the morning, even though the appointment is at 11 o'clock, because they come and sit there and they charge hours. Very expensive. So for prison systems, telemedicine is a wonderful cure. And so, but this is a catch. As we go along, many things are going to change forever after COVID. But I don't believe that we'll be shaking hands very soon. Okay, and it may become something that will last in our culture, that we may not be shaking hands. The same way we may not be celebrating like Indian weddings where we have 1,000 people in a packed room. Maybe certain things are going to change forever, and telemedicine is something that's going to change forever, and the medicine is going to go because there was no payment before. It was all free service. Now there is a payment, and it's a good medicine, and many of them have no access or affordability to come to physician offices, especially the poorer people and who happen to be more sicker. Thank you.
Absolutely. Mohan.
As I said, Mohan Mallam, I have been practicing near Los Angeles area, internal medicine and geriatrics since 1987. So this health business is getting more and more popular recently, as Dr. said correctly. People love to do the telehealth now. The patient is happy, and because of the transportation issues, especially the senior population, they love to have some kind of treatment from their homes, type of thing, from the doctor's office. And about 50 to 60% of a practice, I practice internal medicine, geriatrics, solo practice, practice. And 50 to 60% of my practice now is on telehealth.
Yes.
So we start with on the phone, and if you need to then examine the patient, then we switch over to the video conferencing thing. And fortunately, as Dr. Premadigar just said, the government has recognized the importance of telehealth and started reimbursing. And not only that, they reimburse the same amount as the telephone visit versus the in-person visit. So now more and more telehealth is getting more and more popular. I think it's going to stay. Only there are some exceptions, for example, surgeons. Of course, they cannot do the surgery on the phone. So surgeons' business might go down if they start the thing. And another thing is that, this malpractice insurance carriers, they started covering our malpractice insurance at least until the COVID crisis is over. And after that, probably, what the premiums might go up. So telehealth is there going to stay, and
I think so. I think you're right. Telehealth is going to stay.
I mean, I should not say empty, but
telehealth is going to stay. I personally feel that it's going to stay, and also I'm personally betting on telehealth. Like inflammatory bowel disease, for example, they don't get a good care. So I'm trying to focus on that. Inflammatory bowel disease, there are only handful of experts in a given region, so we can direct it to them. So I think telehealth is going to stay. Okay, because of lack of.
As a comment.
Yeah, I just want to say that I think the genie is out of the bottle. As the medicine is evolving, telehealth will be there. Where it lacks is there should be reimbursement for group therapy, from support group, for rehab, for those kind of things which can be done in a safe place from the physician's office or from the healthcare providers. As the medicine evolves, telehealth is not going to go away. This is the new way. Just get used to it. We probably like how to feel the patient, but it's not happening anymore.
Yeah, we may have a 20%.
Just one quick comment. The government,
okay, go ahead.
The US government has recognized the importance of telehealth. That they added a lot of course that could be done on the telephone to telehealth. Like for example, in the hospitals, you can even do telehealth on critical care patients also, as well as rounds, discharge summaries and all that. And the government has added a lot of new codes to promote the
that's right. And also transmission of disease will be less. Transmission of disease also will be less.
But the lawsuits will increase. Just be careful, because what you say is
it won't replace. Thank you. Sorry. Thank you very much, Professor. Okay, 5 minutes untara, mari you have to leave. Okay, sorry. Okay, maybe one sentence comment, Jane, before you leave. I thought we'll have one sentence comment by all the all the speakers.
Arogyame Mahabhagyam. Let the rulers realize this and let them be prompt on health issues and education. They are two very important aspects in any country, and they are unnecessarily giving a lot of importance to defense, which is not right.
Okay.
I think all of you are educated. You should put some pressure on the governments, and they should allocate more funds for health, research, science, and that is the way we have to protect ourselves. Dharmo Rakshati Rakshita. Namaste.
Thank you very much.
Thank you. Thank you very much.
Prem
Reddy garu namaskaram. Prem Reddy garu namaskaram.
Prem. Yeah. Okay.
Andariki namaskaram. I take leave.
Yeah. Okay. Thank you. So, before everybody has a statement to make, can Mohan Mallam, chairman of NATA Foundation, or NATA not Foundation but Advisory Council, can you give a brief, brief vote of thanks?
Vote of thanks. Just on behalf of the organizing team for this webinar, I would like to thank first of all the prime initiator of this event, Dr. Ashish Reddy garu from Alabama.
Thank you, Mohan.
And thanks to Dr. Prem Reddy garu, Dr. Nagesh Reddy garu, Dr. Varaprasad Reddy garu, Dr. Kiran Patel, and Dr. G. Reddy Prasad garu. In spite of the busy schedules, they participated in this webinar.
Kavita.
Us and the community on this new disease, which has a lot of uncertainties.
Yeah. Kavita.
Thanks to Dr. Talwar and Dr. Kavita Reddy for their valuable input during this weekend webinar. And new challenges are ahead for all of us, as we just heard. And thanks to NATA leadership team, President Dr. Raghu Reddy Gosala, Secretary Ram Reddy Yala, Treasurer Naran Reddy Gandra, and other NATA IT leaders, Subba Reddy, and others who helped us behind the scene to make this event a lively one. Because there is, believe it or not, there's a lot of information technology involved here. This kind of meetings, as you all know, and without help, this webinar would not have been possible. And Dr. Suresh Reddy, our special thanks to you, although he's not in the audience here. Dr. Suresh is probably the busiest nowadays among all of us. In spite of that, he joined and contributed to this. And before I conclude, I just want to have one announcement that NATA is currently organizing several virtual events, competitions such as Miss USA, Mrs. USA, fashion show, beauty pageants, cultural competitions, etc., etc.
Super singer, sir.
Yeah, some entertainment after this, and then hopefully we'll get through this unexpected COVID-19 crisis ASAP. Thank you.
Okay, yeah. Thank you, Mohan. Thank you very much. Yeah, thank you. So we'll have the final comment.
NATA website, nataes.org, they got a series of entertainment events posted on that. Okay, that's all, Ashish.
Yeah, thank you. So we'll have a final comment, like 1 or 2 sentences, not more than 2 sentences. So let's start in the same order then. You can start first and then we'll go with Nagi and we'll go like that. So go ahead, one final parting comment.
Who is next? Me? I'm the next?
Yeah.
Okay. I don't have a comment except, appreciate, so many brilliant people taking time. And Dr. Talwar, if I get COVID, I will call you as a doctor.
That's what I was thinking.
I have personal experience of the disease, so you can call me anytime.
Right. Thank you for your participation. And I don't know whether you know it or not, everybody than you and Kiran are ready guys. Every one of us are ready. We all come from one place, like Patels. I don't know, there are many.
But I want to tell you, I speak 5 Indian languages.
Okay. Not Telugu, I would suppose, right?
Thank you.
Yeah. Appreciate everybody's coming. And Nagesh already taking, he's a busy gastroenterologist, but he's sitting very patiently and not even shaking. Thank you. And your father was my examiner. And one day in a light-hearted moment, I'll tell you how my oral exam went with him. It can be told openly, that's why.
We have some stories to tell also. Positive.
He was an excellent examiner to all of us.
Yeah. But they're all positive.
Yeah.
Yeah, that's right. So, okay, Nagi, your parting comments, take home message.
For this, and I think my comment would be that I think we realized with this pandemic that preventive health is extremely important. To stay healthy and then you are healthy in spite of whatever happens. This is extremely important. And we also realized not to stigmatize this disease because that's the most important problem. To stay optimistic, we are sure that this is going to be a small blink in the history as we look along and that we'll get over all this. And to stay en route, optimistic would be very important. Thank you.
Yeah, thank you. So who is next? Dr. Talwar?
I'll say two sentences in two different languages. This is a disease which is a blip on the future evolution of our thoughts. It will go away and human mankind will win. But I want to say the other one in Sanskrit for everybody. It is the core of Ayurveda, which is swastha rakshanam, aturaksha vichar prashmanam, means take care of the healthy, but protect and relieve the ailing of people's suffering. And that's why we're in this business. And let's keep doing this. This disease will go away, another one will come. But we all have to be optimistic. Thanks.
Thank you. So next is Kavita, right? Kavita.
Okay, yeah. So that was beautiful, Dr. Talwar. I like that very much. I think this pandemic represents a huge opportunity for healthcare and social reform. And, let us not lose sight of the power that we have to make those changes and affect future generations. So despite what's happening, I have a high degree of optimism for our way forward.
Dr. Prasad?
Just like Dr. Kavita said, there is a lot of opportunities with this realignment of COVID, what she did. So I'm always out of the box guy. So there's a lot of opportunities available. And as far as my branch is concerned, in diabetics, please be careful. And most of you are probably about 50 or 60 and have comorbid conditions. You use the social distancing, wash your hands and be active, take care of blood sugars, and because we are at a little higher risk. Other than that, this shall pass and we'll definitely win this COVID war also.
Yes. Okay, I'll throw my 2 cents also. This COVID is going to go away one day, and but the life is going to change. It's not going to be exactly the same, but it probably come back. We'll probably not this way, but in between, we'll meet somewhere halfway, I think. So there may be some opportunities that come out of the learning curve during this epidemic, and we need to learn those opportunities and use entrepreneurial spirit to use these opportunities, to this learning to help the mankind. I feel like there are opportunities in this bad epidemic. And learning, about improving the health, like sleep and obesity, all those things. So I think some positive things certainly will come out of this pandemic. Thank you.
Yeah, I just want to say one
comment. Ram Reddy, let him speak also.
Yes, yeah, right.
Yeah.
Go ahead.
Please, all of them.
Yeah. We keep saying that thanks to the healthcare professionals and all. So doctors are God sent, God gifted. Okay, so we are fortunate to have doctors like you, and NATA is really proud of you. And thanks being in this great profession and helping all the patients, not only in this one, but this COVID reminded about the doctors. and how important those doctors are. And you're doing thankless job, and especially Premanna and everybody, Dr. Varaprasad Reddy garu, Dr. Nagesh Reddy garu, Padma Bhushans. So we are excited to see all of you, Prasad G. Reddy garu, Kavita Reddy garu, and Dr. Talwar and Dr. Kiran Patel, everybody whoever participated. We are really grateful and thank you, all of you.
Thank you. That was heartfelt. Heartfelt thanks. So, anybody else?
Raghav Reddy.
Raghav, mute lo no.
Unmute.
Mute lo no.
Unmute. Okay.
So I have one question. Everybody wants to hear one thing. When that vaccination is going to come, everybody is going to ask them which month, how much time it takes. That's what everybody wants to hear. When I talk to everybody, like all of the people asking one question, when it's going to come, what month?
It's a good question, and we're all waiting. We are all anxiously waiting.
And one more question to Dr. Talwar. So there is autopsy findings in China and Europe and here. What are the autopsy findings, Dr. Talwar?
Are you talking about the autopsy of the lung or autopsy of the kidney? The autopsy in the lung actually shows the fibrosis. And those patients who survive severe infection, mild infection, there is no damage to the lung. So think of this, 81% of the population, those 81% of the people who get the disease are not going to have any residual damage. They are fine. These are the ones we want them to recover at home. Very good. Then another 15% of people get a moderate disease in which they may need to come to the hospital and get admitted. Most of them, if they have no underlying major diabetes, no underlying uncontrolled hypertension, they have no underlying immunosuppressive disease, like they're taking cancer treatment, something like that, they will also recover. 1 to 3% patient in different studies are going to be left with damage to their lung, to their kidney, and even to other areas of the body, or maybe stroke or encephalopathy, means they can't really think. They say something has happened that even after recovering, I'm not the same person. So the autopsy findings are showing glomerular damage in the kidney. So people are developing renal failure. They're showing fibrosis in the lung, so that patients then, even when they recover, they are short of breath. They may even be left with having to walk around with oxygen. In the brain itself, there is small vessel blockages, something like strokes that you get. So some of these people then come out and even though they've gotten better, but the changes in the brain autopsy have shown that the small vessels which are in the brain, we call that small vessel vasculitis, that has occurred. So even with the severe disease, even when the patient recovers, it's not the same. But that's a very small percentage of patients. Let's not be afraid of this disease. Most people will recover and will not have damage. The only thing is recovery time. As the disease severity is a little bit more, the recovery time is a little bit more. Usual flu, you get better within 10 days. A moderate COVID virus infection takes at least 8 to 12 weeks to fully recover. And that's something that we've been telling our patients and helping them as well. I hope I answered your question.
What about DAC changes in lungs?
The changes in the lung that they have seen with the endothelial damage, which shows small vessel thrombosis and the fibrosis, once it sets in, it has its own course and it will slowly continue. That's where the dexamethasone and the anticoagulation is helpful. So that continues, and that's with our worry.
So a lot of people asking Dr. Talwar, well, a simple question. What is the treatment protocol in USA?
For
treatment.
Okay, the outpatient treatment. Let me quickly tell you, if there are physicians in this group and you really want to know this, follow the CRP, follow the D-dimer, and follow the serum ferritin. CRP is a very short half-life, ferritin has a little longer half-life, and D-dimers somehow predict the development of vasculopathy, means development of thrombosis in the DVTs, pulmonary embolism, strokes, etc. So once the patient gets discharged, If his CRP should be normal, his ferritin should come down to normal, and D-dimer should also come down to normal. If doesn't come down, you need to anticoagulate that patient for at least 30 to 40 days. You can use Coumadin, you can use NOACs, newer oral anticoagulants, whatever it is, because that is going to stop the prevention of the development of these things. The other thing is those patients who are symptomatic, even with mild cough or shortness of breath, and etc., you can still use prednisone in those patients as well. And please, outpatient medicine, use prednisone in these patients, low dose prednisone. It will help them. It will help with their symptomatic relief. It will help with their fatigue, etc., etc. And third thing is rehab. Teach them breathing diaphragmatic exercises. We all breathe, but we usually use our chest. Try to use your diaphragm. Take a deep breath in and let the abdomen go out, then breathe out and let the abdomen go in. This is the diaphragmatic breathing, and that helps to decrease the atelectasis both during COVID and after COVID. These are the few things that I'm telling my patients. I do agree with vitamin D and vitamin C, as Dr. Nageshwar Rao also pointed out. In our patient, vitamin D is deficient in Indians, and that we believe is one of the reasons why so many Indians get this. The AAS receptor 2 density is higher in Indians, even when we are thin. So that's why thin diabetics in India, or thin diabetics who are here, are also getting the COVID infection because the receptor density is higher in those patients. Okay.
Thank you.
What about zinc? What, Doctor? I know we have a lot of questions, but Dr. Talwar, about zinc, do you have any comment on zinc?
He said that before. He said zinc is helpful.
Zinc, vitamin C, and vitamin D.
Okay, but you take a hyper dose when you get trying to become sick, or you just what kind of dosage do you take?
Zinc supplements. Go ahead, Dr. Rao.
There are no randomized studies with zinc, but the basic pathophysiology is that zinc actually inhibits the virus from entering into the cells. And it's been shown that zinc, when combined with antiviral drugs, is more potent. This is based on cell studies. We don't have really randomized studies. It was very difficult to do that with zinc. What is advocated is 50 milligrams every day. So this is a dose that's advocated. But I said it's very difficult to prove it in clinical studies. But because zinc is harmless, people say, why not anyway take it? There's no problem.
But short term, it should be okay to take higher.
Yeah, short term.
Yes, zinc has been proven to be helpful in common cold, and that's why it's available in CVS, and you can see that. The same thing, zinc tablet.
Yeah, viral infections.
Viral, common cold viral infections, rhinovirus infections.
Yeah, that's right. Yeah, okay. Okay, then any other comments or any other thoughts or anything? Otherwise, we can conclude, I guess. I
think we're done.
Thank you all. Have a happy Father's Day tomorrow, guys.
Yeah. Thank you, Prem. Thank you, Nagi. Thank you.
Yeah, thank you all the speakers. Thanks for your time, and it's really valuable information.
Yeah.
Okay, bye everybody.
Thank you all.
Bye.
Bye.
Yeah, done.
రామరెడ్డి గారు మన ఇద్దరే ఉన్నామండి, మన టీవీ మన ఇద్దరు ఉన్నాం.
One second.
అదే రికార్డింగ్
let's stop the live.
Already.
Yeah, it's still live.
Oh.